est en zone de confort. Bon, ça c'est pour le brasier. Ça c'est sur la dame. Sur le ceci. Voilà. Voilà, je vous souhaite la bienvenue à tous. Juste quelques mots avant de commencer pour préciser. Normalement, vous avez des casques de traduction qui vous ont été proposés.
Before we start,
Ceux qui n'ont pas,
just
de casque
to
de traduction,
remind you that
on
there
a
are
des casques
headsets
disponibles.
which will help you
avoir beaucoup de
listen
variétés
to
d'anglais
the
différentes
English
et
interpretation. So there will be interpretation
voilà, si vous avez
into
le moindre
English,
doute,
but
surtout,
also
n'hésitez pas à
into
prendre un casque
French.
de traduction.
This afternoon we
Autre
will have a
information
number of
pratique pour ceux qui ont des
speakers
casques
with
de traduction.
different accents. For those of you
Pour,
who
allumer
did
votre
take a
casque, vous
headset,
avez besoin
to
d'appuyer
turn it
environ 3
on,
secondes
you need
sur
to
le petit
press for
bouton noir
about
qui est au
3
centre du
seconds
casque.
at the
Voilà,
center
les boutons sur
of
les côtés sont pour
the
régler le volume. Appuyez
device,
bien 3
and the
secondes
buttons to
pour
the
lancer la
right
traduction.
are to increase and lower volume. But you
Hi
have to
everybody,
press at the
welcome.
center for about 3
Just a few words to
seconds.
remind you that you have translation headsets available. They've been proposed to you. For those who didn't take any translation headset, we have some few more here. And just to remind you that if you want to use them, you just have to press about 3 seconds on the main button of the headset. So just press 3 seconds and it will be good for you. Thanks a lot. And we're just going to begin in a few minutes. Et la régie me donnera le top pour le départ. Voilà, on règle un dernier tout petit détail avec nos duplex. Et puis on va y aller, comme chaque année, vous savez qu'on aura beaucoup de monde à l'extérieur. On va être en duplex tout à l'heure avec Bangkok, on sera en duplex avec...
Please bear with us. We are about to start in about a few minutes. There are still some technical hiccups that we need to correct. But please bear with us. We are going to start in a matter of minutes. Thank you.
Bonjour, bienvenue à tous.
Good morning and welcome to everybody for this new conference of the Observatory of e-Health. So for all of those who've travelled here to Lavaur, near Toulouse, France, to the Pierre Fabre Foundation, welcome. And welcome to all of those who are following us remotely from their homes, their offices, with the University of French-speaking citizens. So throughout the day, don't hesitate to ask your questions and just say hi. And say, hi, I'm following from Abidjan, from Delhi, from Bangkok. It always makes us so happy when we receive these messages. So the program of today is as busy as it is fascinating, because we will be talking about artificial intelligence when not one day goes by without AI bringing along some novelties. And we will be looking at the contribution to health in countries of the South. And to introduce this conference, I would like to invite Beatrice Garrett, who's director of the Pierre Fabre Foundation.
On peut applaudir au passage quand même. Bonjour.
Good morning, ladies and gentlemen, and all of those who are following us remotely, and I know there are many of you. And welcome to Andoise, the headquarters of Pierre Fabre Foundation, for the opening of this 7th conference of the Observatories for e-Health in the countries of the South. So Pierre Fabre is an association of public utility and created the observatory within the framework of its missions, which is improving access to health and drugs in countries with limited resources, with the firm conviction that innovation and digital transformation must also contribute to improving access to health of for everybody. So for the past 7 years, the observatory's work has allowed us to identify and document 175 digital projects in 80 countries, and to support 41 winners to help them scale up and disseminate best practices. Each year, for the annual conference, we try to identify a theme that sheds light on the challenges, the opportunities, and stakes of health in the countries of the South. And generally, there are a lot of internal debates among our expert committee. And I must say that this year, the question of the role of artificial intelligence was obvious to us, because it has really monopolized everybody's attention, creating as much hope as it has conjured fears. The hope brought by the use of artificial intelligence in the field of health are tremendous. This is developing diagnostic supports that are reliable and fast, health protocols that can be used everywhere by everybody, contributing to finding new molecules. And the fear is maybe the loss of our cognitive faculties and the increase of inequalities, disinformation, to the extent that we know that researchers themselves have called for people to take a break in artificial intelligence. And some people call this a sanctuary. The European Commission itself, via its president in the Union's speech, pleaded for the creation of a panel of global experts who would be in charge of assessing the risks of artificial intelligence for mankind on the model of the IPCC for the climate. So this global debate, within this global debate, so one thing is sure, is that access to knowledge and information is essential. Therefore, it is essential that the North and the South have an equal footing around the table during these discussions. If indeed we are heading for a social revolution that comes from the application and generalization of tools developed by artificial intelligence, this revolution must not be held without being inclusive, fair and sustainable. At our level, at our modest level, and without ever losing sight of our objective, which is how can we take action in the field to improve things, we have organized today's debates around two themes which we think are essential. First of all, diagnostics tools and support, because in the field of artificial intelligence, in e-health in countries of the south. It's the tool that's most used. And then ethical questions around 2 roundtables with some case studies and sharing of experience. So today also has the vocation of giving the floor to innovators from the south. So we have 4 wonderful products that will be presented by their champions, 3 of whom were able to come here to be with us today and share their experience with us. So I'd like to thank them warmly. I would also like to thank all of our experts who are with us today, our innovators and our thinkers who will help us shed light and share their experience and knowledge with us. I would also like to thank the historical partners of the Observatory, the French Agency for Development, the University Agency of French-speaking countries, the Asia IF Information Network, and the Fondation Avenir. I think that all together we hope to make today's proceedings one where we will learn things, work towards solidarity and collective intelligence. Thank you very much. So let's go from artificial intelligence to collective intelligence. As I said, this conference is broadcasted directly on internet. You can choose your language, French or English. Please do send us some highs and some reactions on YouTube. It will be in the YouTube chat, on LinkedIn or Facebook. You can put this in the comment, and we have quite a few people who are already saying hi to us. So for all of those who are here, we have messages from Burundi, from Kenya, messages from Gambia, Nigeria, Africa is in number today, but not just Africa, because among the campuses that have joined us today, there's that of Maidan, Bangkok in Thailand, where we will be going immediately, which groups together the faculties of medicine and pharmacy. And in this campus, we have Dr. Buchai with us. Dr. Munchai, good morning. Can you see us and can you hear us properly?
Alors, évidemment, bien sûr, ça marchait.
So, of course, it worked 5 minutes ago when we tested the system. Dr. Bunchai, can you hear us from Lavaur?
Alors, on reviendra.
So, we will come back. Not to worry, we will come back to you in a few minutes' time. And we will continue our reflection on artificial intelligence. It fascinates us as much as we feel. Improving access to health in the countries of the south. And this morning we are lucky and we have the tremendous honor and pleasure to be hosting Aziz Ayed, who works in the prestigious MIT, the Massachusetts Institute of Technology in America, MIT, which 2 or 3 years ago, I think, through your professor, brought out the first antibiotic entirely created by artificial intelligence to fight against E. coli. And it immediately had a performance that far exceeded anything mankind had been able to achieve. And so Aziz Ayed will be taking the floor. He is a graduate in mathematics. He has a graduate from HEC, and he's a researcher in MIT, and the generation that will see artificial intelligence unroll over the coming years. So I will leave him the floor to give us his vision of artificial intelligence.
C'est allumé normalement.
So thank you very much for hosting me here, and thank you for your introduction. I was lucky enough to talk yesterday evening with the winners of the foundation and members of the Pierre Fabre Foundation. It's an honor to be here today and to talk to you about AI in medicine. As Lionel said, I'm a researcher in the MIT with the professor Aziz, and we work on a lot of subjects related to artificial intelligence and the unrolling of these methods we're developing in the labs to try to bring these methods to patients throughout the world. I don't know if we can see the slides.
de l'autre côté là-bas. Et on peut les faire, voilà, on peut les faire défiler. Voilà, elles arrivent, elles vont arriver sur l'écran.
Ok, parfait. On va peut-être revenir en arrière du coup. Ok. Alors, et du coup, dans le cadre de...
So within the framework of this presentation, I would like to begin by presenting the state of the art of AI for healthcare and to explain where we stand today in terms of research and new discoveries and all of the challenges that we meet, all of the problems that we have to deal with when we develop models and try to use them. And then we will move on to some practical examples of methods we've developed and how we use these and how physicians use these, doctors. So, of course, as Lionel said, this year in particular has seen a boom of AI in a collective consciousness. And there are lots of tools that everybody has access to, everybody can use, and everybody can see just how powerful and impactful they are. In particular, ChatGPT, which achieves performances that we never thought we would achieve. And the AI is sat at the bar exams and school entry exams, etc. So it can create images from descriptors. All of these innovations and creations of AI have raised the question of how we can use this in the field of healthcare and how we can innovate in the field of healthcare and medicine by using this technological expansion. And I think that there are many topics around this, and we can find a lot of labs and researchers who work on very different subjects, from diagnostics to the discovery of new treatments, through the use of operations in hospitals and how we can see which patients arriving in the emergency ward should be treated first, etc. So all of these subjects are there's really the livestock of research around these subjects, and there are many players that are looking into this question. So to give you more specifically some examples of subjects that, some success stories, as Lionel presented, that 2 or 3 years ago in the MIT, some researchers and supervisors discovered the first antibiotic using artificial intelligence. This antibiotic is called lysine, and it is an antibiotic that fights against bacteria for which we had no treatment beforehand, such as the E. coli. So how do we develop these antibiotics? We create algorithms that are able to model the molecules that we wish to synthesize. That goes from stability of the molecule to toxicity for patients, to the effectiveness against bacteria. Will it be effective? Will it work? So the interest of this is that rather than having traditional methods, we test tens of thousands of molecules in the lab to see what will work, what will cost a lot of money, and what requires massive screening. And we can use this to make a short list of promising molecules and then to test them. And this is what we did with lysine that we're talking about, and we're in clinical trials currently with the FDA trials, and which has is very promising, and it needs to go through all of the verification steps to make sure that it works well and that there are no problems with this method. Another big field of AI in medicine, which is very fashionable now, is that of imaging, and how we can use imaging to automate diagnosis, to automate things for patients, follow-up of patients, be it for cancer, many applications. But we will come back to that question shortly. But what we realize, in particular in the field of research, is that we have developed methods that work very well, and we try to prove that these tools can be used in many situations. It is very difficult to explain to the general public how they work. Of course, you can understand this. There are a lot of challenges around AI and a lot of problems that are very difficult to manage and which are very difficult to understand from the point of view of researchers and also from the point of view of doctors and the governments. There is a lot of hallucination around AI, so I'll come back to that later on. And there's also the bias that is within AI, because they're trained with databases that are created by human beings, and these methods are trained on training models that mimic human functioning. And the danger of this type of thing is to reproduce the biases created by human beings in their methods and have AIs that are completely biased and that could accentuate inequalities rather than correcting them. There are also many questions around private data and how to make sure that data remains private and that they not be accessible to everybody, that there are no leaks onto internet when we present the methods. So it's all of these subjects that make the question of adopting these AI methods rather tricky in hospitals. So to come back to the question of hallucination, there are two examples that are quite famous and we often use to illustrate this question. On the left, you have a model that was trained to recognize shapes. So it's a vision model, which has existed for many years, and they're very performant now. And they're just as performant, if not more so, than human beings to recognize shapes in pictures. And we realize that this model kind of puts a square around the subject and says it's a person or something else. And so it so happens that this example of model, which looks very performant when we test it and validate it, we can realize that it's very easy to trick it, and it's subject to hallucination. So the example here is that we train the model, and every time a musical instrument appeared, the musical instrument is in the hands of a human being. And of course, you could never see a monkey with a guitar in its hands in nature. So it so happens that when we give this model a picture of they give the AI a picture of a monkey with a guitar in its hand, it identifies it as a human being. So that's the Attaway. There's also the Attaway effect. There is a company called Berkshire Hathaway, and we realized that every time Anne Hathaway had positive news, the values of the shares of Berkshire Hathaway increased because the model thought it was the company and not the actress. So it's easy to trick this model. And if we think in the terms of health and hospitals, it could be very dangerous when you're developing AI methods. For example, if we develop a method to diagnose lung cancer, and we train it with a model that we get from a partner hospital, and it so happens in this partner hospital, most people who have lung cancer have more than 60 years old. So this model would probably qualify people under the age of 60 as healthy. So we just need to give a bit of freedom to the model and to take decisions based on the model only, and we might miss cancer in the under 60s. So these are the obstacles to developing the deployment of AIs, and that we're trying to overcome. And there are many subjects that come back that doctors talk about and the people we work with. There is also the question of 60-year-old patients. We have the same problem with ethnic origins, and the model are trained by local researchers with local data, and there's a big challenge of access to data. Generally speaking, it's difficult to access generalist data. Therefore, models are trained on local data, and it's very difficult to generalize things. We train it, a model that's trained in America will have difficulty working in Africa, for example, and that's a real topic for researchers. But it's a subject that already existed in traditional medicine, and we'll see that later on. We can see that traditional medical methods that analyze risk scores are also biased and have trouble working in different populations. So we could continue talking about that subject for a very long time. And everything that's happening now, as I said, it is a very vast topic, and its growth is exponential. There are articles every day on new discoveries, and with this, new controversies and scandals every day. But I would like to focus a little bit more now on methods that exist and examples of things that have been unrolled and that actually work well, and which are the things we can draw inspiration from to develop an ethical, responsible AI that would allow us to make the bridge between countries of the north and countries of the south, where we could really level the ground up, in particular in terms of diagnostics. So I will speak about two models we developed within the lab for lung and breast cancer. We thought about that subject because my supervisor had breast cancer about 10 years ago that was diagnosed very later on and was very difficult to treat. And so she wanted to develop a project around that, around breast cancer. And it's a subject that is very easy to understand because if you look at the figures, when breast cancer is local and diagnosed, it's cured at practically 100%, but when it becomes regional rather than local, the cure rate is 85%, but when there are metastases, it's only 27%. So there's a real challenge for early diagnosis of cancer. It's the same thing for lung cancer and all types of cancer. So there's a real subject of early diagnosis here. And in traditional medicine, there are methods which allow us to predict the appearance of cancer or not. This method are based on traditional factors which are age, family history, breast density, etc. And these methods have an accuracy of around 63%. So AUC is a metric that we often use in AI to quantify the performance of a model. And an AIC of 1 means that it perfectly predicts the future. And so it says it will predict this woman in 2 years' time will have a cancer or will not have a consent. An AOC of 0.5 means that it's random predictions, meaning, you know, it's like tossing a coin. So it's a 0.5 of AUC. So 63 is not that good. And it's this score of 0.63. It's a method that we use today for risk factors for breast cancer. So we asked the question about how we could improve these methods and how we could make something that is more accurate and really tailored. Because this risk factor method is based on age, on family history. For example, if we take 2 sisters who are don't have a big age gap, we have a risk score which is very similar between these 2 sisters. Of course, it doesn't really have any meaning because we should be able to have a different score for these 2 women. So we wondered whether we could use X-ray pictures to predict the risk. And in fact, we can identify existing tumors in breast X-rays, and we can see that this will help us to predict the possible appearance of cancer. So what we wanted to do is for 2 sisters, if they have very different factors, we will have very different scores. And even the same women, the structure of the breast will change and the risk score will change. With traditional methods, one woman would be the score would be the same for their entire life. So we developed this method using artificial intelligence with what we call a neural network in order to take a healthy mammography and to prevent the risk of cancer at 1 to 4 or 5 years in the future. And we compared this method to traditional risk factors. And the figures you have here are on the local population around the MIT in Boston. So we can generally see that the performance of our model, which is called Mirai, which means future in Japanese. I don't know why we chose this name, but that's what we chose. And we can see that in terms of performance, it's well above traditional methods, around 78% accuracy against traditional methods, which was 63%, as I said earlier on. But I also talked about biases and biases that exist in traditional medicine. And we can realize that this traditional method, which we call the TC score, which is the method that is used throughout the world, it was developed in the States, but it's used in India, in Africa, in Europe, etc. This method, when we test it on white women, has the performance that we're familiar with, which is 63%. When we test it on Afro-American women, the effectiveness drops to 58%, Asian women to 53%. So as I said, 53% is the equivalent of tossing a coin. It's randomly saying whether a woman might have cancer or not. So what we tried to do with our method is to, based on these findings, we knew that there were these problems with the traditional method, was to train these models with patients from all different backgrounds and ethnic origins to make sure that the model remains effective, whatever the ethnic origins of the patient. So as we can see, for American populations, if we divide it by ethnic origins, the performance remains around 73%. And then we took the analysis first. So we thought, well, can we, use this model in hospitals throughout the world and make sure it works throughout the world? So it's a model we already trained, so we're not training it anymore, but we're just testing it on populations throughout the world. So we worked with hospitals in Israel, in China, Taiwan, United States, Sweden, and we published a research article where there's a conscientious analysis of the results throughout in all these countries, and we can see the performance is maintained everywhere. So there's an accuracy of around 75% in all of the countries. So we thought we would reproduce the experience for lung cancer. So we won't go into the technical details, but this year we published the results on lung cancer, and results are similar, if not better, with AI and its ability to predict the appearance of a cancer in 1 year's time with 86% accuracy. So it's not because we identify a tumor in this lung. We just say this person has to come back in 3 years' time because that person will have cancer in 3 years' time. So the possibilities are tremendous, whether it be to diagnose cancers in countries of the north where people often, they should be having examinations every 2 years, but you might develop internodal cancers in between these mammographies. And when we see them sometimes, it's already too late to treat the cancer. So with this, we managed to diagnose these cancers. I'm Tunisian, and I know that in Tunisia, there are many women who come and do a mammography once, and then they say it's okay, and they don't come back for another 10 years. And actually, with this type of method, we can say, well, for questions of means and access to health and hospitals, etc., with this method, we can say to them, no problem, you don't need to come back for 3 or 4 years, but you must come back in 4 years' time because you will probably have a problem in 4 years' time. And to the contrary, we can also say for women, we're sure there's no risk, no problem, you don't need to come back for another 5, 6 years. And, to relieve them of that mental load. And just a little aside here, one criticism and when we're trying to develop these methods is question of interpretability. An advantage of traditional methods is that it's easy to interpret. We're able to say, well, I think that you are at risk because your mother had cancer, because you have this gene, you have this risk factor. When I explain the methods that we use with images, it's very difficult to say to a woman, well, AI saw your picture and said that you're at risk, and we can't really explain why. But that's a real subject that it is difficult for us to deal with. So it's difficult to develop interpretable methods. We say to AI, why do you think this is the case? And show me the region where you think it is. And we can see an area where there's more light and potentially a cancer might develop in that place. So there's a real question of, do we prefer to have methods that are 90% performant and we can't explain, or 65% that we can explain? So it's not a rhetorical question, it's a real question. Because I'm not a doctor, I don't see patients on a daily basis, but I'm not the person who has to explain it to the 10% for whom it didn't work and say to them, well, it didn't work because, well, we don't know why, because AI thought that it was one thing and it was something else. But with pictures, it's interpreted. With traditional methods, we say, you don't have this gene, so normally speaking, you're safe. So let's come back to the unrolling of these methods. After developing these methods, we had a real problem of trying to unroll these methods so it could be used everywhere, with this optic of allowing the greatest number to benefit from them. So we realized that it was really complicated. Everything is published and you can download them on the internet. They're free to read, but despite this, it was not adopted. So we set up an initiative where part of my work for last year was really, first of all, to develop software around these methods that are very easy to use and which run on laptops, which are very intuitive, that anybody can use, and doctors can use. And then to go and knock on the doors of hospitals across the world and say, well, we've developed this, it's free, and I'm there to set it up for you. Are you interested? And with this, therefore, last year we worked with 30 or so countries, and we tried to really focus on countries of the South. We started with Latin America because they're close by, Colombia, Chile, Peru, Brazil, Mexico. Then we went to Asia, Singapore, China, Taiwan, Hong Kong. and throughout Asia. And now we're trying to approach Africa. We have partnerships in Nigeria. We're looking for people who would be interested in using these methods in Africa. So this is a message to you. If anybody's interested, you'll see my mail at the end. Please do reach out. I wanted to talk about these two examples because we can see, as I was saying, there are a lot of questions around AI and the fear of what will happen with AI. Will it replace doctors? There's a question of data leaks. I just wanted to show these examples to show you that it's possible to develop public free systems that can be used to level the ground and to provide the same diagnostics capacity, be it in the back waters of Tunisia or in a very modern city. So we just need to do everything we need so that these methods are unrolled and that they are effective. A lot of labs are working on these subjects and in the same direction. And so there are a lot of studies around this. And from our point of view in our lab, our next subject in the field of diagnostics will be to use and develop these methods for other types of cancer, prostate and others. And now we're also looking, I was speaking earlier on the discovery of new drugs. So we discovered this antibiotic 3 years ago. Now we're looking at immunotherapy and the discovery of new antibiotics, and also questions of correcting biases in traditional methods, because if these biases existed in the breast cancer diagnostics methods, they exist everywhere. So we need to look at how we can correct these biases in existing methods. And there's a subject that's very important to me personally, which we're working on, and that's organ transplants, which is, I don't want to say archaic, but it's a process that hasn't evolved greatly for a long time. And it has a lot of biases. To give you an idea, in the United States, a white person, the average time to find an organ is 3 or 4 years. Somebody of Afro-American origin, it takes 7 or 8 years. And that's because the traditional models are anchored in statistical genetics, which create inherent biases for access to organs in people of different ethnic origins. This is a very important subject for me. We're working on this in my lab, and we're open to collaborations in this area. We would really like to find hospitals throughout the world with whom we can work to try to develop new methods around organ donors. So if anybody is interested in this topic, please do contact me. So to conclude, as I was saying, these methods are a true opportunity. They give real hope to really level the playing ground. And I think that there's a lot of work to be done around this, and we need to, all of the researcher teams and companies working on this must all come together with the hospitals who can use them as well. I think this is the main obstacle that we've come up against. It's moving from hospitals into moving from research into hospitals and the adoption. So we're working more and more with hospitals and governments to develop these tools at national levels. And that's why I'm very happy to take the floor here, because it's this type of initiative, I think, that will help us to allow this method to be adopted at a global level. Thank you very much, Aziz Ayat, for this brilliant introduction.
On voit bien que l'IA, toutes les questions que pose l'IA, que ce
all of the questions raised by AI, be it scientific or mathematical questions, and a lot of ethical questions for medical corpus. You talked a lot about research and application. Moving into application is already a reality for those who are not in the world of AI. You talked about breast cancer, and the Strasbourg Hospital has been using this for the past 6 months, where there's an experience where we compare the human eye and the AI eye when in detecting breast cancer. And AI has already detected 4 or 5 cancers in the past weeks that hadn't been identified by human doctors. And yet, no later than yesterday, the hospital in Rennes gave us figures about the reorganization of their emergency ward, in particular for small trauma. And now AI analyzes the images. And you can have a validation with the doctor, but AI detects the lesions better than a human eye, apparently. And it allows us to save 1.5 to 2 hours of waiting time by patients in the emergency ward. So it is used. It is also used in hospitals of the south, and this is what we will see now.
Voilà, et avant de lancer cette première table
Before we launch this first roundtable, there are so many people writing into us, so I would like to thank you, those who were writing in from Germany, Seydou, who's watching us from and Fada and Gourma, from the east of Burkina Faso. Have a lot of people writing to us from Mali, messages from Bangladesh, from India, from Togo, from Paris. We have a hello from Mongolia, from the remote dermatology service department in Mongolia. And a hi from the mental health team platform in Benin. They're all interested in AI and the unrolling of AI in countries of the South. And this is what we will now see in this round table, where we have Dr. Siku Muntenge, who is an ophthalmologist. Please do come up. He's an ophthalmologist.
Originaire du Kenya.
She's from Kenya and works today in the Institute of Ophthalmology of Rwanda. And you can tell us how you're developing the diagnostics with AI in Rwanda. Thank you very much for having traveled to be with us here today. Peggy Brie, who's a product manager with Google Health and who's traveled here from San Francisco. And we can give her a round of applause. She's going to join us up here. Peggy, where are you? If you could please join us up here. And then we will see with you how Google contributes to the development of health tools and with artificial intelligence in the field of dermatology, among others. And remotely, we hope that things will work. From Switzerland, we have Professor Alexander Navarini, who is in charge of the dermatology department in the University Hospital of Basel. And so it's not Professor Alexander Navarini who's here, but it's Professor Paisan, who is also with us remotely, a professor of ophthalmology who's working in the hospital of Bangkok. Good morning, Professor. Can you hear us from Bangkok?
Yes, I can hear you.
Merci.
Can you hear me?
Yes, that's perfect. Merci beaucoup d'être avec nous aujourd'hui. Et c'est vers vous que je me tourne tout d'abord, puisque dans un pays comme la Thaïlande.
So I'm turning to you because in countries such as Thailand, there are 7 million diabetic people. That's practically 10% of the Thai population. With the risk of these people of developing what we call diabetic retinopathy. And that's a disease that can be properly treated if we catch it in time. However, if we catch it too late, people can become blind. In the 90s, for example, in Thailand, 1/3 of the blind population was blind due to this disease. That gives you an idea of the scale. And therefore, the authorities decided to train nurses and healthcare workers to really go out and meet the populations, in particular rural populations, just to, do some ophthalmological examinations. Professor Paisan, how does artificial intelligence fit into the government strategy in this respect?
Well, this is a good question. We, in the past 10 years, we train our helpers, who's not doctors. Yes, as you mentioned, we train nurses, we train technicians to be able to read retinal images. We are able to take retinal images. Retinal is the back of the eye, and so we train them in the past, and we establish the system of having the person to be able to detect diabetic retinopathy, to get referral in the past, since 2013. We can train them to have accuracy about 85%, 70 to 85%. We are happy. But recently, we found that there's a model from the Google Health to be able to detect referral to ophthalmologists with accuracy 95%. So we are curious. So we call them, we try to collaborate with them, and we are able to validate their AI system in our Thai population. And we found that the accuracy from the AI is about 95%, as they mentioned in their paper. So I think this is a critical point, because the accuracy of the AI is better than to implement the AI system fit into our current screening program, which is a nationwide screening program. But we slowly increase use of the AI with the in conjunction with our trained graders for detecting referral to ophthalmologists. That's what we are doing.
On a un petit souci de son. Je sais pas
So
si
we have a sound problem. I'm not sure if the interpreters have been able to understand properly because there are sound problems. Professor, today you are
d'instruments, de machines spécialisées en intelligence
equipped with AI machines, and you're equipping the people to go out into the field for these diagnostics. Where do you stand in terms of the unrolling of these tools, and what percentage of the population are you targeting with regard to the screening of your population?
We target the patients with diabetes. Can I share my screen? I think this may give you a little bit of overview of what we are doing in Thailand. Can you see my screen now?
Oui, c'est parfait.
So this is the picture of global impact of diabetic retinopathy. Is the leading cause of blindness in the working population in the world, and the number of people with diabetes, especially diabetic retinopathy, is growing, and especially the number of patients with vision-threatening retinopathy. As you can see, it may increase from like around 40 million people to be like 56 million people in 2030. And well, the way of screening diabetic retinopathy is to detect cases for referral to ophthalmologists. There's a recommendation by the American Diabetes Association and the International Council of Ophthalmology to screen patients with diabetes at least once a year. It means patients with diabetes should have eye examination once a year. And because we don't have enough ophthalmologists to do the screening, to do the examination, so we use the photos. As you can see, the upper part is the picture of retina without retinopathy, and the lower part is the picture of diabetic retinopathy. As you can see, the difference is quite obvious. So we are able to take the cameras to screen diabetic retinopathy, to take pictures of retina of patients with diabetes in communities. In the past, we trained in the middle upper photo. You can see we train personnel who's not doctor to be able to read these images, to detect retinopathy, to refer for treatment at tertiary care centers. This is what we are doing in the past, but currently we are in the kind of transition phase. Instead of training the personnel, we try to use AI. You can see the sensitivity for the trained personnel is 75%, but for AI it's 95%. So we want to detect cases for referral for treatment, timely treatment, using AI now at the moment. This is what we are doing in Thailand.
Professeur, vous nous montrez effectivement.
Professor, indeed, you're showing how you're unrolling AI massively in direction of the concerned population. You also compared the reliability of an AI diagnosis as compared to a diagnosis with a human eye. You've done some studies on this subject. What are the results of these studies, and what are your feelings on the matter?
Oh yeah, this is a good question. So we conduct a study we call retrospective studies. We use the existing images, like around 12,000 images, and we used 3 retinal specialists, one from the US, one from India, and one from Thailand, to read the images as the truth. And we add some images, and we use AI to read same set of images, and we found that, as I showed the slide, we found that the accuracy of AI is like 95%, and the accuracy of the our trained graders only like 75%. That's a retrospective study. Then we move on, because the result is quite good. Then we move on to conduct a real-time prospective study. It means we didn't use the existing images, but we conduct a real-time analysis. It means the patients who come to the clinic, we ask them to sign consent, allowing to use AI for diagnosis. And we ask the nurse to take the real pictures, and the nurses will upload the real pictures into the cloud. AI is in the cloud. AI in the cloud's going to analyze the images and then send the result back to the screening site. And AI is going to delete the system in the cloud is going to delete all those images, send only result to the nurses at the screening site. And the nurses at the screening site is going to give the results to patient right away. So this is going to take like less than 2 minutes. And this is we call like a prospective study, real-time study. So we found that in the real-time study, the sensitivity of AI may be a little bit decreased from like 95% to be like 91%. But specificity of the AI system is still the same. It's about 95% comparing to the retrospective study. So now during the last fiscal year, from October last year until like September this year, we're able to have more than 20,000 patients already. And I think the accuracy is about the same. We're able to detect the cases of 90% accuracy. Thank you.
Merci, professeur. Reste avec
Thank
nous.
you, Professor. Do stay with us. These figures are very impressive, these AI diagnosis figures. So I turn to Dr. Siku Mathenge, because you have a similar project that you're leading in Rwanda, and you're you have the first machine that will soon be with you. We're not going to come back over the technology, because the previous speaker has explained the advantages of these technology, and you're going to be using the same technology. But I would like to talk to you about the way in which AI leads us to rethink the healthcare for the patient. And it's very impressive, because when we prepared this roundtable, you said, well, this AI equipment, I don't want that in my clinic. I'm not the main person who should be receiving these machines. Can you explain why?
Oh, please take a microphone.
So what we've done with our project in Rwanda is not about it's not about testing the accuracy, but actually using the AI in the field directly. And for me, it was important to do this because we have very few ophthalmologists in Rwanda, meaning we have almost no retina specialists. And previously, I used to go to a clinic and sit there and screen people with diabetes and then send them for care. I could only do this like 3 times a year, because the rest of the year I'm doing my normal work. So I wanted a solution that allows me to do only what I can do, which is treat the patients. And so that's why we put an AI solution called CyberSight AI into these diabetes clinics and trained non-clinicians how to use the application. And now I only receive patients who need to see me. We were a bit worried about the acceptance by patients. And when we started the project, we used to ask every patient and say, you can get your diagnosis done by humans, or you can get it done by artificial intelligence. And the difference will be how quickly you get the result. And 99% of the patients wanted to get an instant result.
C'est extrêmement important.
This is, what you're saying is really important, because very often the medical staff, the main criticism says that, the patients won't trust in an AI diagnosis necessarily. And you're saying that yet they do trust it.
Exactly, and I was worried. In Kinyarwanda, the local language, a computer is called the thing that never gets confused. So maybe that's why they had so much confidence in AI. But it was an important question for us, because introduction of telehealth in Africa sometimes is limited by people's acceptance of being diagnosed by machines. But for my patients, what was important was getting that report as quickly as possible, because a lot of our systems, that's where they fail. You go for an X-ray and you don't know what it said for several days. So I think the ability of AI to generate these instant reports was very important. But also what I was looking at is there's no need of screening people if when you tell them they have disease, they don't go for care. So my study was, so after they are told you have disease, will AI improve their going to the doctor? And what we found is that giving them an instant report improved them going to the eye doctor by 30%. And for my patients, it was because it saves them another journey. So they come from far, and on the same day, they will see their diabetes doctor. They can actually go to the eye doctor the same day. It saves them the transportation. It saves them, losing another day when they could be working wherever they work. So that was really interesting for me.
Extrêmement passionnant ce que vous nous
So what you're saying is so interesting. That means that in this the patient treatment, where place is for AI, the immediate AI diagnosis? Where does this come into play?
Sorry, I didn't follow the question.
Je voulais dire
I wanted to say that when you're dealing with the patient, you're saying that nowadays patients must go and see an ophthalmologist, and then another diabetic specialist, and then another place to have treatment or go and see their GP, and then go and get the medicine. It's a lot of travel, and you say, well, a lot of patients, but it's not specific to the South. It's also true in the North. A lot of people actually give up taking care of themselves because it's too difficult for them and it's too split up. So how can this automatic diagnosis facilitate the treatment of the patient?
Thank you. This has been really important for us because it's hard for people to find time and money to go and see doctors. So for diabetes patients, their care can be very disjointed. They go and see the diabetes doctor who tests their sugar, maybe their blood pressure. Then they have to see the heart doctor, the kidney doctor, the eye doctor. It takes a lot of time in their lives. So AI allows us to put the eye check exactly in the same room where they get their diabetes check. And again, when we asked our patients, we said, so the addition of this extra test, do you feel it's wasting your time? You're taking too much time? And they were all said it's better to take time today than for me to be told go to see another doctor. So that's what we found.
Extrêmement intéressant, de manière disruptive.
Very interesting. It's a disruptive manner of establishing a diagnosis and to revisiting the patient pathway. So a lot of questions on AI coming up here. We talked a lot in the introduction about the notion of databases. How did you train these machines to analyze and diagnose with such accuracy if you have a diabetic retinopathy, for example, or other eye diseases? Did you naturally find databases? Did you have local databases, or did you need to go and retrieve databases from the north? How did you go about it?
So I didn't develop the AI platform. I was assessing its use. But what I found interesting with CyberSight AI is that I had access to the machine engineers who do this stuff. So at first, when we started working with it, we did have problems. I felt it was not interpreting my patient's retinas the way I thought it should. And the first step was, to feed this engineer with as many retinas from my patients that I had access to. I'm lucky because I had done a large study looking at retinal diseases in Africa, so I have a huge curated database of retinal images, and I could give them to these engineers and then make it more accurate. I was not happy with the way, for example, it was looking at the optic nerve. Maybe because of the excessive pigmentation we have, I felt this is not correct. And what I really liked about CyberSight AI is that access to the engineers so that I could say, I don't think this is right. And they were willing to work with me until we got a product that was accurate. But I do think we need to do that. We need to manage data from different populations and not just give them to people, but participate in how that data set is used. And I think that's what's lacking. A lot of people now want to collect data from Africa, but that's it. After they collect it, we don't know what happens. But I was privileged to be able to participate in how this was being used to improve the model.
tout cas, je retiens dans vos propos.
Well, in what you're saying, there's a very important notion of the quality of data that is analyzed by AI, and in particular, the local or regional nature of this data. And you can't exchange everything. You might think that a human eye is a human eye, but we need local databases in order to analyze human eyes from your country.
Au niveau du business model.
In terms of the business model of these solutions, there is the cost for the patient, cost for the health system. When there is a structured health system, how did you work out this question of the business model? How can you financially guarantee the development of these solutions?
Yeah, that's a really important question, and I haven't answered it because I was lucky to have access to CyberSight AI for free. But it's unrealistic to think that these AI platforms will continue being free. So we do need to cost them and see what is realistic for populations like mine to be able to access. I think we need to start developing those economic models and presenting them to our governments and our insurance systems. But I imagine that it can never be more expensive than my time as a retina specialist seeing the patient. So that's the argument I would give to government, that if I have to look at this image and grade it, my time is very expensive. AI will never be that expensive. Also, if I get somebody with disease early, it probably costs like 20 euros to treat that problem. If they come later and I need to give injections, it's about 1,000 euros. If they need surgery, it's like 3,000 to 5,000 euros. So we have convincing evidence that using AI to detect disease early will save money, and insurance companies and government health systems should be able to appreciate that.
Mais aujourd'hui, de manière concrète,
But today, concretely, who is paying for these solutions? Do the patients pay 100%? Does the clinic pay part of it because you're saving time on the examinations? Does the government participate to the cost of examinations or to the construction of algorithms?
So currently, patients just pay as if it's a consultation. We haven't costed what is the cost of the imaging. Unfortunately, AI works with images, and the gadgets we use to image are also expensive. So that's an additional cost even before you reach the cost of AI. I think that's a gap that we need to discuss and understand. But because there's been such little deployment of AI in our region, we haven't yet got models that allow us to cost and then determine who will pay.
beaucoup de réactions sur le chat.
So we have a lot of comments here on the chat. A lot of people who are reacting to say that the detection of a diabetic retinopathy is a very impressive project. And this question that you have just answered as to whether these projects will be accessible to the less fortunate population. So I'm going to turn to you, Professor Paisan, who is still with us from Bangkok. Professor, are you still with us?
Voilà, on vous retrouve en duplex. Merci.
So, a quick question for you, because there is the question of the cost for developing these solutions. You have chosen to work with Google to develop your solution, your algorithm. Why did you choose to turn to an American giant?
Well, this is a good question. We collaborate with them because we saw their paper, we saw their published paper, and we have our trained personnel who have accuracy around like 80%, and we're happy, but their accuracy is better. That's why we collaborate with them. And during the collaboration, we do a lot of study together, and there's no cost of their AI. And currently, the screening of diabetic retinopathy in Thailand is taken care of by the government. For the people of Thailand for getting a screening. And since we are conducting like study together, during the study, there's no cost of AI as well. So actually, there are no cost of AI for Thailand yet. But after this phase, I think after the study, we will take a look at it. I think the cost for Thailand will be very reasonable because it's going to be taken care by the government, part of the usual coverage insurance scheme as well.
Merci, professeur, pour cette réponse. Et on a
Thank
la
you,
chance-
Professor, for this answer. And we're very lucky to have with us today somebody from Google. Thank you for being with us, Peggy Bui.
Question toute simple.
So a very simple question. We can see the different agreements you have with Thailand and other countries to develop Google solutions. What is Google's interest today in the medical sector? For YouTube, you can understand because there's a big advertising market that they can gain from this. For driverless cars that are officially authorized in San Francisco, we understand the financial interest of Google going to this. What is your interest in the medical field?
Well, first off, thank you so much for inviting me here. I'm so honored to be here and listen to all the great work that's being done globally. I think when people hear Google, naturally people think about, well, this is a big corporation. There must be some sort of other angle here. But the reality is that all corporations are made up of people, of individuals, people in this room. And health is such a universal topic with a lot of personal appeal. A lot of people here at our organization, organizations everywhere have a personal health story, a family member, someone else who's been affected. And so for us, a lot of the motivation for pursuing AI and health has been rooted in recognizing this huge global need, as Dr. Paisan and others have already highlighted. So, at Google, certainly for many years now, we've been good at using AI to classify objects, to localize objects, to summarize entire scenes, right? And so several years ago, a group of very passionate employees got together and said, hey, look, if we can classify, what type of flower this is, if we can localize, oh, here's the bus in this map scene, if we can even say, oh, this is a group of rugby players enjoying a lunch break, right? Can we take these same AI capabilities and be able to apply that to something that will meaningfully impact a lot of people's lives, like classifying, how severe someone's diabetic retinopathy is, or localizing in this biopsy, this is where we see the tumor, or this is where we see the abnormality, or summarizing a radiograph, or actually more recently even a smartphone picture of someone's skin and saying, this is what this could be, this is what this looks like, this is a fracture in the metatarsal or something. And so it's really about leveraging a lot of high quality engineering talent and feeling like we're putting it to good use in the world.
Et on sait bien sûr que les talents d'ingénieurs sont...
Yes, the engineering talents are tremendous in Google, and you have such a capacity for research in Google. And Professor Payson, recalled this. They have capacities and skills that are there. You have agreements with Thailand. You have agreements with other countries. So, how concretely do you intervene to support the countries who turn to you for research around artificial intelligence?
Yeah, that's a great question. We see in these partnerships that the other countries are true partners. And to be quite honest, the program in Thailand would not have been so successful had the partners not been so genuinely interested in making this possible. And you've already heard from Dr. Chiku that she herself contributed with trying to make the AI better to make it work for her local population, right? So in these partnerships, certainly we bring a lot of engineering expertise, and we help guide in terms of teaching the local community about the capabilities and limitations of the AI, but we really look to the local communities to understand what is that salient problem that you're trying to solve. How can we best use these technologies to help you with that problem? What are the gaps that you've identified so that we can make the project better for everyone? So we don't go into these collaborations assuming that these solutions will work perfectly out of the box. Conversely, we actually assume the opposite, that it's not going to work perfectly, and we look to the partners to help us understand, okay, in what scenarios is it most appropriate? How does this fit into your workflows? Because we don't want to disrupt something that is already working well.
Je profite d'avoir quelqu'un quand même de Wanjiku.
So I'm going to take advantage of having somebody from Google with us who is at once a doctor and who works in the world of engineers, because we have so many questions from all different areas about AI. The question of databases keeps coming back there on the table with artificial intelligence, and we saw how with Dr. Siku how important it is. One of the paradoxes is that a lot of researchers with AI work with academic databases that come from hospitals, and you say it's good, but it's not necessarily always the best solution. Why?
Yes, that's definitely an interesting topic, and so a lot of times when we leverage data to train the AI models, these data can come from hospitals, clinics, academic centers, where it's actually a trained professional who's capturing the image. So either it's a doctor, it's a nurse, it's someone who's trained to capture the image nearly perfectly or to the best of their ability. But in the real world, we have everyday people who are just quickly snapping a picture. This is especially true if it's not a medical grade image. So for example, if it's not a fundoscopic image or a chest x-ray or something like that, where it's just someone with their camera, we see a lot more variance in the real world in terms of how pristine the image is. So AI, as Aziz mentioned in his talk earlier, it captures all the inherent biases of the data that it's trained on. And so one of our very early realizations was we had this data set come in from an academic center. It was a beautiful set of data, very high quality, high resolution images. And we realized that sometimes when doctors are really worried that this could be cancer, they often put a ruler in the image to measure the size of a lesion or to measure whether or not something is growing in severity. And the AI tends to pick up on whether or not a ruler is in the picture as a proxy for, does this person have cancer, right? And so we have to recognize that in the real world, the range of pictures that people submit is much greater in diversity than what we might get in an academic center, where there's a totally different purpose and intent for that original image.
Et ce que vous nous dites, et merci de le préciser.
So thank you for clarifying this. It's extremely important in terms of databases. There is, of course, the local, regional aspect where we need to come close to the population, but we also need databases that collect together the things that the nurses and people in the field and operators which are degraded quality, which is as compared to hospital. So that's something that's very important for the North and the South. Among the other paradoxes, let's talk technical matters. One of the paradoxes, which is very complicated, is the fact that AI will find solutions and diagnosis that work. We're not always able to explain why and how they find it. That is a true conundrum. And a few years ago in the Nice hospital, they compared patient cohorts with cancer 4 years before, 4 years after. We gave the case studies to AI, and the AI managed to identify who would develop a cancer, but we couldn't explain why. So we look at things through different lenses in Europe and the United States. You say Europe often asks us to prove and to explain how we do this. The United States would tend to say, well, look, it works. Why should we bother trying to prove things? Could you explain, therefore, how you can manage your relationship with Europe?
Okay, that's a very challenging question.
Indeed.
Indeed. I will say Europe tends to be much more cautious from a regulatory standpoint when it comes to a lot of these new technologies. And with AI, as many others have already recounted, we can't always explain exactly how it works. Certainly we do try. So we have some projects where we look at things, what we call saliency maps, where we can say, think of it as like a heat map almost, where certain parts of the image we can light up and highlight and say, this is what we know that the AI is focusing on, so that at least if a human is looking at it, they have some understanding of, oh, this is why the AI thinks this, this, and this. We're working on some other projects where we're trying to even summarize that in text and say, okay, this is the pieces that the AI has weighted with what's important for its ultimate recommendation. But at the end of the day, there's always going to be cases out there where we don't know why the AI thinks it is this way or that way. And so it comes down to a philosophical question of, what would you rather, right? Would you rather have something that's very highly accurate, but you can't always explain why? Or the status quo, which we have seen in many studies that the AI does perform better than like an aggregate group of doctors, right? Because it is taking that input, that collective intelligence from all the millions and millions of data points that it's seen. So to your question, I don't know that I can fully answer it because I feel like you would need someone from the European regulatory bodies here to kind of address how they think about this. But I do think it's an important question to solve because already we see with these new technologies with large language models, a lot of AI is being deployed worldwide, where Europe is kind of being held back as the exception region. And so it may very well be that a lot of these new technologies either bypass or come to Europe late as a result. And I'm not really sure what the right answer to that is.
Dr. Mathenge, vous souhaitiez compléter?
Yeah, it's
you want to
interesting listening to that question because we are neither in the US level or the European level, and it's important for us because the deployment of AI right now in my region is pretty much unregulated, and we don't have the policies and frameworks to guide how we continue. But I think that we need to choose a ground that is useful so that it's not too restrictive or stifle innovation and what we can do with AI. So I hope that as African governments start developing these policy frameworks, and I think that's one area of support that Africa needs. It's in developing the appropriate frameworks that we kind of reach that good balance where we don't block things, but we also don't just allow unregulated use of our data or interpretation of our data.
Merci beaucoup de cette contribution. Effectivement, ce sera aussi l'une des grandes questions de la table ronde.
Thank you for this contribution. Yes, this will be a topic of the roundtable this afternoon. I have the impression that every time we talk about AI, we open a window, then another one behind that, and it's endless. Among the last paradoxes that I wish to highlight in this roundtable, there is the fact that for AI, you say in Google, we can launch a project in a certain region of the world, for example, in the United States, around AI, and it doesn't work. And then we realize that, to the contrary, the same AI project works elsewhere in the world. So could you give us some concrete examples of this? Because it seems crazy.
Yeah, I guess I would clarify and say that it's not that it doesn't work in the US, it's more that so sometimes when we train certain models, we use data that mostly comes from the United States. And so our expectation is that these models would work well in the United States, and in other regions, it might not work so well because there are regional differences, and we expect what we call a distribution shift when we deploy these models to other regions. And yet, surprisingly, what we've learned is that sometimes these models actually end up working even better in some other regions, which was the opposite of what we were kind of taught to believe, right? And so we don't have a clear explanation for this quite yet, but I think most people recognize that the United States is a region that has immigrants from countries all over the world, and so that may play a role in the generalizability of some of our models.
Extrêmement fascinant. Dr. Mathenge.
Fascinating, Dr. Mathenge.
I don't have case studies, but I can talk from some of my experiences. So because the AI we use in ophthalmology depends so much on imaging, as Peggy said, the quality of the image you get determines how well your model will perform. So even with the CyberSight AI that I use, when different cameras are used to get the images, then the performance is different. And one of the problems that we struggle with is that there's a trend to want to develop a lot of mobile, portable solutions because people feel like that's more appropriate for Africa or for the poor countries. And I always resist that because my solution depends on a good image. And if a big camera is what gives me a good image, that's what I need. And let me figure out how to move around a big camera. And it's never been a problem. But kind of trying to convince me that a portable handheld camera will be the solution, that causes problem. The other scenario is that a lot of machines use normative data. And we don't talk about normative data. But I remember in a project I was doing, looking at glaucoma, I used the gold standard machine that we use to analyze what we call a visual field. And I just felt that the interpretations were not, they were not tallying with what I was seeing in the patient. And I remember publishing this manuscript saying that I believe the problem is the normative data in this machine. Because it's not based on an African population and what the visual field in an African looks like. And that paper has never been published because I guess it was a bit too controversial. But I wonder, I mean, we get these machines now in existence. How big is the normative data? How diverse is it? And my fear is that some of the things that we're telling AI to do are also based on what those machines with normative data itself that's not representative is interpreting as normal or abnormal. So I think it starts from there.
Passionnant, hein, tout ce monde autour de l'IA.
It's so interesting, the question of data, of norms, of the specificity of population and data-related data, and also the question of the quality of images that we were able to use, and its subsequent interpretation by AI. And to add to this reflection, I suggest we head off for Basel, where we have the Professor Navarini, who is in charge of the Dermatology department in the University Hospital of Basel. Professor,
vous nous entendez
I don't know if you can hear us properly. I can see you on the... Can you hear us properly?
Bonjour. Alors je sais que vous êtes francophone, si vous avez le choix.
Yes, hello. I know that you're French speaking, so please do speak in French.
Qu'on explore un autre projet.
So we would like to explore another project with you, this time in dermatology in Madagascar.
Moi, je parle français, parce que comme ça, la tradition, peut-être, c'est plus audible. C'est difficile entre l'anglais et le français. J'ai pas entendu l'anglais quelquefois. Okay. Super, merci pour l'invitation. C'est un grand honneur.
Écoutez, on va pouvoir le faire en français si vous le souhaitez. On a un service de traduction de toute façon qui est automatique derrière. Oui, je reposais ma question. Je voulais avec vous qu'on rentre dans un projet de dermatologie que vous menez à Madagascar avec de l'intelligence artificielle pour aller détecter des pathologies en dermatologie, peut-être plus sur les enfants dans un premier temps. Est-ce que vous pouvez nous expliquer ce projet que vous menez?
Oui, très brièvement. La prévalence de dermatose en Afrique, c'est très élevé, et spécialement dans les enfants. On voit beaucoup d'eczéma impetigo, c'est une maladie bactérienne. Alors les champignons, Tinea capitis, scabies, c'est très fréquent et très souvent. Les medical officers qui sont en charge de détecter, faire le diagnostic et traiter ces patients, ils n'arrivent pas à faire le diagnostic, même que les médicaments sont là et peuvent être achetés dans plusieurs parts de l'Afrique qui est challengé. Alors, je ne parle pas de toute l'Afrique, c'est juste pour ce slide, on a généralisé un peu, mais évidemment, il y a beaucoup de différentes régions en Afrique. Et à Basel, en Suisse, ah oui.
Non, je disais là sur le projet sur Madagascar, justement, vous dites, vous avez le souhait d'aller détecter 4 maladies, plus précisément.
Exact, c'est 4 maladies.
Yes, these 4 diseases also.
4 maladies.
4 diseases which
très différents. Alors c'est facile.
Are very different.
pour un AI de faire la
And it's
différence.
very easy for an AI to establish a diagnosis.
Ce que je montre ici, que c'est la
So,
dermatologie qu'on fait.
what I'm showing you here is dermatology.
Alors, on a...
Et, normalement, on fait la dermatologie
So,
avec les docteurs humains.
Alors, je résume, parce qu'on a des tout petits
So we have some sound problems. So you're developing this project for.
Okay.
I think you just need to.
Okay. Je disais donc on a 4 maladies, eczéma.
So I was saying we have 4 diseases: eczema, impetigo, tinea, and scabies. And you are currently developing a project so that social workers and doctors working remotely can take a photo with their smartphone, send it to via WhatsApp to a department and see if AI can detect these different diseases with a simple WhatsApp photo. Professor, where do you stand today in respect to this study and its organization through time?
So we wanted to study this study first in Tanzania, because Tanzania there is also a dermatology training center. We have now switched to Madagascar, and we are going to Madagascar to set up the center in 2 weeks. And then we will do the ethical protocol and everything in the local, according to the local regulations, and we expect to start the study in about 6 months to 1 year. It will be a platform study, so we will not just use our own AI, which we have trained on about 5,000 pigment-rich pictures, but we will also allow other machine learning models to be included. There is a model of a Bell AI, there is a model by WHO. So basically, we will always compare these models, and this is perhaps a little bit hard to see in the study phase A to C. We will compare the models to the actual human consultation, which is the gold standard. So basically, trying a stepwise approach to see whether the AI ever reaches the accuracy that the human physician, dermatologist can provide. The disadvantage that we have in dermatology is that, you know, the retina by Professor Paisan, you go in the world, but as you can see, it's very different from machine learning models that are trained on skin. If you do this on pigment poor skin on Europe, typically, it will not translate to a good accuracy in Africa. So we had to retrain machine learning models, and these will be open source. So we will be happy to share all these, including the pictures.
Professeur Navarini, est-ce que vous voyez une...
Professor Navarini, do you see a significant difference between the same type of study that you lead in a country of the north and this type of study in a country, in a southern country?
Well, there are many differences, starting from legal differences, cultural differences. We need to take a lot of time and patience from both sides to really have the study be done by local persons as leaders, as it will be in Madagascar. So we cannot do the study like we would do in Switzerland, but we believe that we can do it on an equally high quality. It just needs a bit of a different approach, and we had to learn a lot about how things are done in these countries, and still are learning, of course.
Et toute dernière question, est-ce que ce
And a
projet
final
peut
question, this project that you're developing with Madagascar, is this a project by default because there aren't a sufficient number of dermatologists in Madagascar, therefore they're turning to AI, or to the contrary, could it prefigure the type of medicine that we will soon have in Switzerland, the United States and the UK, where we will use the same techniques that allow us to do the mass detection of diseases?
I think I understood. So whether these can then be translated back to the perhaps to some extent, but I think we are really doing this because there is a lack of trained human dermatologists in Madagascar and in many countries in Africa. So AI is a potential, has these conditions that are very distinct visually. We have, if there were, it would be very different. And I think in Switzerland and in other countries, we're going towards decision support for dermatologists and health professionals, including nurses and so on. We don't aim to directly replace the AI. And it remains open whether we can actually ever do that. That is the study subject, but it is not quite clear that this will be achieved to 100%, of course.
Merci de cette réponse.
Thank you for this answer. I would almost want to ask you the same question, Dr. Mathenge. You explained that in Rwanda that you're doing this mass detection thanks to AI because there is a lack of qualified people. But do you think that this is prefiguring a medicine of the future?
I think that AI has a really important role in filling those gaps, but we need to be careful because most of the uses of AI now are at the screening level, so at disease detection level. And in medicine, we like to say no survey without service. So one of the worries I'm beginning to have is if we develop all these models for identifying disease, and we don't at the same time strengthen the services for treat disease, then the population is going to be disillusioned, because I think it's unfair for me to go to someone and say, you have this, and then I don't do anything about it. And I'm not sure that things are moving at the same speed. So yes, it's helping us fill a big gap in terms of disease detection. We must not lose the game when it comes to then managing those that we identify.
Une dernière question rapide.
Just a few quick questions. We can see that AI is really disrupting the service that can be offered to the patients, but it's also disrupting the position of the healthcare professionals, because we can see in all of our debates, AI is really cleaving. Some are very for it, and then others are really against it. People are rather in between. And we can see a lot of ophthalmologists and dermatologists who don't want to hear about AI because it also questions their very profession. So what is your reaction with regard to this and your feeling on the matter?
So personally, I've never felt threatened by AI. I think what happens right now is we do so much outside what we should be doing, and what AI is doing is allowing me to do what only I can do, and that will allow me to get better at what only I can do, which is in treating these retina conditions. But I don't have to be the person who looks for them. Yeah, so that's, I think you can only be, people are threatened because they don't know. There's so much about AI we don't know, and then if you don't know, you hear the EU is discussing this and saying it's going to end the world, and you hear AI is going to replace doctors. All you're hearing is all these alarming statements. But if you are participating in its development and understanding that it's coming as a solution, because I think AI also should be developed as a solution, not that it's developed and then we look for the problem that it can solve. If you are involved at that level, then it's not a threat. That's how I see it.
Peggy, Même question en quelques
Peggy, same question for you in just a couple of words. Won't AI be a key revolution for the healthcare professionals, whether they're happy about it or not? It's there, and we will be using it.
Yeah, I mean, I certainly do think AI is going to change how we practice medicine forever. And I speak to this from a lens of both being on the technical side as well as being a physician. I think whether or not people will want to hear about AI or not, patients are going to come to you at some point and talk about this, right? And so it's always good to at least understand what's out there. It does seem scary, but anyone who's participating in the active development of AI really gets this kind of see the robustness of which we analyze and test a lot of these models and features. And there's real promise there. We've certainly run some studies where we had patients use AI, we had doctors use AI, and what we saw was that it actually strengthened the patient-doctor conversation, helped patients to be more engaged when they came to their doctor, because now they're informed, they know what they should be talking to their doctor about, and the doctors actually feel like they are more productive and get more out of the interaction. I definitely agree with my colleague here that there are lots of things that doctors have to do that, quite honestly, are not the best use of doctors' time. And the AI kind of frees up that mental space to really use our skill sets effectively. And I think that more people will realize that over time, as the demand for doctors is certainly not going away, it's only going to increase.
Donc, content ou pas content, on va tous utiliser, on utilise déjà tous.
So we're already using this artificial intelligence on a daily basis, and we will use it increasingly in the future in the field of health. Thank you very much for this very interesting roundtable. I suggest that we take a couple of minutes, because I'm sure there are a lot of questions, comments around what has been said around AI and health application, both in North and the South, because we can see that most of the questions are common. So for those of you who are looking, following us remotely, I have a lot of questions coming up. If you can put the name and the country of the questions as well. So we're going to go to Bangkok for the first question. And in the room here, we have two microphones that we'll be handing around for questions. So in Bangkok, we will be with Dr. Bunchai, if he's still with us this morning. Doctor, the floor is yours for the first question of this morning. Questions are common. So for those of you who are looking, following us remotely, I have a lot of questions coming up. If you can put the name and the country of the questions as well. So we're going to go to Bangkok for the first question. And in the room here, we have two microphones that we'll be handing out the question. So in Bangkok, we will be with Dr. Bunchai, if he's still with us this morning. Doctor, the floor is yours for the first question. You heard us remotely. I have a lot of questions coming up. If you can put the name and the country of the questions as well. So we're going to go to Bangkok.
Hello, can you hear me?
Questions. And in the room here, we have two microphones that we'll be handing out the question.
Hello, can you hear us?
Yes, we can. Yes, yes. Please, on a un petit souci de traduction qui tourne, qui a l'air de prendre un petit peu de temps ou qui tourne en boucle.
Hello, can you hear us? Hello? Hello?
Yes. Alors, on va retrouver Bangkok un petit peu après. Je pense qu'on a un petit souci de traduction et de retour de son de la part de Bangkok. En attendant, on va faire tourner le micro ici. Et puis, je poserai les petites questions des internautes. Qu'est-ce qui prend la parole en premier pour les questions?
I have a question. It's interestingly, a few years back, when we wanted to even start teledermatology, we are not even talking about AI, but we have, the dermatologists said that we have enough dermatologists in the country, in urban and rural why do I need a teledermatology? So do you think we will come to a stage where AI solutions, where we have enough specialists, or in both rural areas and urban, will want to use this as a solution?
Is that question for me?
Celle d'entre vous qui veut.
Okay, I can try and say something. I think we need to ask the question to the right people. I'll give an example about a platform called M-Pesa, which is a mobile money platform developed in Kenya, and which I think is the best in the world. Had you asked bankers whether M-Pesa is useful, they would have said absolutely not. Yeah, and nobody asked them. The M-Pesa was developed, the population embraced it. It brought banking to like 90% of the unbanked population in Kenya. It has, World Bank says it has improved the GDP of Kenya by 2%. Nothing else has done that. So I think if you ask me as an ophthalmologist whether something that seems like a competitor to me is good, you'll get the wrong answer. What I think with AI is, as Peggy said, we need to develop good solutions. The users don't care what the dermatologist thinks, don't care what, they will embrace it if it's solving a problem that they have. That's what I think.
D'autres questions, d'autres remarques?
Any other questions, any other comments from the room here?
Allez-y, Alain Labrique, de l'OMS.
Je peux rester assis?
Oui, bien sûr.
So I'm going to say in English, but I think this was, first of all, a fantastic morning session. Really great discussion, really grounded examples from people who have been using AI in the field, and from clinicians who have been at the front lines of this work. I think the one thing that strikes me that we haven't really brought up yet in the conversation is nuance. AI is not new. I just looked up a Lancet paper from 2020, and both in Europe and in the US, over 200 software as a medical devices that use artificial intelligence and machine learning have already been approved and are in use by clinicians, by hospital systems, benefiting patients. So lest we forget that this is not something that just happened last week. It's critical for us to understand the nuance of dynamic AI versus static AI, AI that is trained and then left as a static algorithm that then every input always produces the same output. So I'd love to hear sort of the reaction from our panelists in how nuance comes into this discussion. I'm very cautious about the use of the word fear when we talk about AI, because I think we don't want to play in this forum with academics and intellectuals into the hands of the media frenzy that is trying to sell newspapers. And we really need to talk about this in a dispassionate, empirical way. Thank you.
Merci pour cette contribution, Alain Labrique de l'OMS.
Thank you for this contribution, Alain Labrique from the World Health Organization. Are there any questions or comments from the room?
Madame, alors, c'est vite, je vous demanderai à chacun de vous présenter.
I would ask each of you to introduce yourself when you take the floor, so that everybody knows who you are. Hello, and thank you for this morning's presentation. I'm Sophie Deleg. I work here in the Kinabad Ijal Hub. I'm a dermatologist. I have a question for... We said that AI improved diagnosis for diabetic retinopathy. In terms of access to treatment, you mentioned the gap between diagnosis and treatment. How, in practice, can Rwanda... what is the treatment of early treatment of diabetic retinopathy in Rwanda?
Thank you for the question. We have all modalities of treatment for diabetic retinopathy at whatever stage it comes in. I think sometimes we hesitate to introduce technology into African countries because we think that things don't exist. The truth is that excellent practice exists, but usually just in one place. So each country will usually have a center that can provide care that is similar to the rest of the world. And the fear that the clinicians will not be able to manage the condition shouldn't delay the deployment of the AI. It should be support to make sure that they can treat all that. But surprisingly, even in a country like Rwanda, we can treat surgically, we can treat with injections, we can treat with lasers, we have the full spectrum.
Une dernière question, Jai en face.
Merci. This is Jay from Asia eHealth Information Network. I have a question for both the panelists here, Dr. Chiku and Peggy. Dr. Chiku, you mentioned about sharing the retinal images with those who develop the solution. So did you have to follow a certain protocol of anonymizing the information? Because I remember more than 10 years ago, I was associated with a diabetic retinopathy project for one of the colleagues. So we could get the data set from some of the hospitals in India, but there was no regulation, but we had to go through a lot of things before we could actually, of course, the ethics committee clearance and things like that. So did you have to go through this before you supplied? Because it's your own patients, but did you get some informed consent or something like that? Did you inform, was there a procedure that was followed before the images were shared? Of course, with the developers. That was the question to you. And then the second question is to Peggy, usually we say any model is as good as the sample size. So is there a particular metric that says that this is good enough? Is it 500 images, 5,000 images, or 10,000? Is there a particular metric beyond which we can say comfortably, yes, this model works comfortably? Those are the two questions. Thank you.
Peggy en premier, you first.
I guess I can start. Shockingly, no, there's no metric. Surprisingly, what we see is that there are some conditions where you only need a handful of cases for the model to get it right every time, and for us to feel incredibly confident that, wow, the model's just going to know. And that's because if you think about conditions, some conditions are so visually distinct that even you with a human eye and no medical training, you can say, oh, I've seen this. I know what this is, this is what this is, right? And so you can imagine that for those sorts of conditions, the number of cases can be very small. Then there are other cases where they're very nuanced, right? It might be very difficult for even the world's best medical expert to even say, oh, this is what this is. And for those cases, you need thousands and thousands of cases. And so there's no real minimum. The reality is, we have to test and learn as we go, and we test each one, and we see, okay, this is where we feel like we can introduce value here. And when we think about introducing value, what we look at is, well, what is the status quo? What is the standard of care today? And can we improve upon that standard of care, right? Because we're not trying to introduce AI in a way that would degrade care. We're trying to introduce AI in a way where we can say, yes, with this, the accuracy improves for everyone by this much.
Yeah. Thank you, and perhaps I could add something to what you said.
Merci. Peut-être que je peux ajouter quelque chose à ce qu'a dit Peggy. Je pense qu'avec la rétinopathie diabétique, les modèles savent très bien prédire la présence de la maladie ou pas. Ensuite, il y a un peu de mal avec l'entre-deux, et avec la rétinopathie, il y a différents grades de maladie. Donc, je pense que c'est exactement ce que vous avez dit. Pour dire oui et non, c'est évident, mais de voir à quel stade nous nous trouvons, là, il faut que nous avons énormément d'échantillons. Pour anonymiser les données, ça c'est quelque chose que j'ai étudié pour le doctorat. Donc j'ai une série de 5000 images de rétinopathie qui sont gradées.
Even to send to more fields, I had to anonymize them. So they are anonymized, and the point you raise is quite interesting, because I feel now there's a lot of kind of data mining from Africa, where people are being given cameras and everybody's happy to get a free camera, but nobody asks where this image is going to. And as unfortunately we don't have any public cloud solutions in Africa, so it also makes it hard for us to work with our own information, so we are always sending them to other people. The problem I've had with my data set is not the anonymity or the ethics around, it's that I give it to people and that's it. I don't know what they use it for, they don't include me in what goes on. You know, Cybersight AI was the first platform that, you know, worked actively with me to improve. And I think that there we need to guard against that, people just taking data and we don't know what they do with it.
Merci à tous les deux, merci à nos 4 invités ce matin.
Thank you very much. Thank you to our 4 guests this morning on this brilliant roundtable on AI. We could spend hours talking with you. And we will continue our reflection on AI with countries of the South with another sharing of concrete experience led by the Doctors Without Borders Foundation.
Et on part pour cela à
So we're off to Paris to join Nada Malou. She is with us. Good morning, Nada Malou from the Doctors Without Borders Association. You're in charge of a project that
en Centrafrique
in a Central Africa called Antibiogo. And I suggest that we look at a few pictures that illustrate this project.
En RCA, les activités bactériologie d'MSF ont commencé en 2019. On a eu la chance de pouvoir recruter des super techniciens de laboratoire, mais on a, comme dans tous les pays, des difficultés à recruter des microbiologistes. Ici, au niveau du pays, il n'y a que 7 biologistes disponibles au niveau national et la plupart sont concentrés au niveau des centres hospitalo-universitaires et donc pas disponibles pour tous les laboratoires de bactériologie.
Et on n'a pas assez de laboratoires de microbio. Les seuls laboratoires de la microbiologie qui sont en Centrafrique sont logés dans la capitale. Donc tout le reste de l'arrière-pays sont laboratoires de microbio. Déjà en SICA, il faut rappeler, on a un laboratoire de la microbiologie qu'on a installé depuis 2019. C'est un outil qui va amener beaucoup de précision, beaucoup d'informations aux praticiens et ça va beaucoup nous aider aussi dans nos discussions de tous les jours.
Voilà.
D'abord, dans l'interprétation, il y a des règles que nous, en tant que techniciens, ne sommes pas en possession. Normalement, c'est un microbiologiste qui doit interpréter les résultats. Mais avec l'antibiogo, même avec l'absence d'un microbiologiste, on peut déjà interpréter les résultats.
Et c'est la V1, 5 routines. Ça va permettre d'améliorer la qualité des tests bactériologiques qu'on fait ici à l'hôpital SICA, puisque les techniciens de laboratoire ne sont pas formés à faire l'interprétation de ces tests. Et grâce à Antibiogo, on va pouvoir apporter cette interprétation et donc les cliniciens vont recevoir un résultat directement utilisable pour traiter les patients.
En termes de ratio médecin-patient, nous, en Centrafrique, on a un très bas ratio. Donc, le plus souvent, les patients, ils se lancent dans une automédication. Il n'y a pas de réglementation pour la vente des antibiotiques.
Ce qui est assez impressionnant quand on regarde les patients qu'on reçoit à l'hôpital SICA, c'est le taux de résistance. Donc on a un nombre très important de bactéries multirésistantes, avec parfois des patients infectés par 2-3 bactéries.
À SICA, le plus souvent, on a beaucoup de patients qui sont infectés. On a beaucoup de cas d'infection osseuse, beaucoup de péritonite et de grosses infections des parties molles. Et donc, avoir un bon diagnostic microbiologique, ça va permettre à ce qu'on puisse, dans un bref délai, mettre l'antibiotique qu'il faut. Et donc, du coup, en général, on va raccourcir la durée de moyenne de chez eux, de chez eux à l'hôpital. On va être efficace dans nos prises en charge et généralement diminuer la mortalité. On reçoit l'antibiotique avec beaucoup d'intérêt parce qu'on a régulièrement des discussions sur les antibiotiques à utiliser, les antibiotiques par déduction. Et là, l'antibiotique nous donne tout ça.
Et l'objectif, bien sûr, en 2023, c'est de pouvoir donner accès à un plus large nombre de laboratoires non MSF à l'application. On espère qu'en mettant à disposition Antibiogo plus largement dans différents pays, ça permettra de démocratiser l'accès à des laboratoires de bactériologie, surtout au niveau régional et au niveau périphérique, puisqu'aujourd'hui, hélas, la couverture de la population au niveau du diagnostic bactériologique et de la résistance au niveau des capitales, et ça, c'est pas seulement en RCA, mais dans la plupart des pays dans lesquels un MSF intervient.
Voilà, pour ce projet en Antibiogo.
That's the Antibiogo project. It's always good to see pictures from the field and look at what it really looks like. So we'll leave you the floor for you to add your comments on these projects. Thank you very much. First of all, I would like to begin by thanking our colleagues from the Fondation Pierre Fabre for giving us the opportunity of sharing our experience with you. I just want to come back to the fact that Antibiogo was not developed in RCA. It was the end of the development process, because today Antibiogo is a certified medical system, and the RCA is part of the countries where Antibiogo is used to process patients. To come back to the idea of this tool and all of the questions around the use of different technologies, among which AI. And it was interesting to listen to the round table, because all of these questions that were raised were questions that we were faced with in recent years within MSF and the MSF Foundation. Be it questions about the choice of technologies, so not necessarily AI, but to remain open as to what technology is and which met our needs the best. I think that was what was very interesting. You always have to set off from the problem itself. And even though AI in recent years has been a buzzword with everything that can contribute to diagnosis, it is not necessarily the technology that will best meet the need identified. So to come back to the birth of Antibiogo and the questions that we raised and the lessons that we wish to share and to use to develop other diagnoses, we can just look quickly at the question that we were trying to solve with Antibiogo, and that is antimicrobial resistance. We know that antimicrobial resistance today is a public health challenge, and we know that if there is no coordinated action by 2050, there will be 2 million deaths per year caused by resistance to antibiotics. And we think that this situation has been exacerbated. And the solution to antimicrobial resistance is, of course, multiple, and that's one of the difficulties. But if we set off from human health, that is what we're looking at in MSF, there are 3 possible axes. There's the fact of training physicians to use antibiotics rationally to improve hygiene and infection control, and finally, to allow clinicians to use antibiotics through using antimicrobial tests in order to target the antibiotics. So we need human resources for this. One very striking figure that was confirmed in MSF this year is that in sub-Saharan African, for example, if we want a ratio of microbiologists compared to the population, we need to wait for decades to increase the ratio. In MSF, I'm sorry, the sound is very bad. So there are patients with multi-resistant bacteria. For example, in Jordan, we have 60 to 70% patients that are infected by at least one resistant bacteria. We can also see this in our pediatric projects, for example, in Mali or Nigeria. There are many children with infections and malnutrition and bacterial co-infection with multi-resistant bacteria. Unfortunately, for years, as we had no access to microbiology labs, it was a real blind stop. And we didn't know what the level of resistance was. So for many years in Médecins Sans Frontières, we set up microbiology labs, first of all to diagnose the patients, and then to collect data and document things, and to identify which antibiotics we could or no longer use during the first year for pediatrics or patients with septic conditions. So very quickly, we won't go into the details of the bacteriological diagnosis, but when a clinician inspects a patient, they take the sample, send it to the lab, it will be incubated, we see if there's a bacteria or not, and if there's a bacteria, one of the most important tests is the antibiogram. That is the test that allows us to list for the clinician the list of antibiotics that they can use and those that they cannot use, as the bacteria has developed resistance towards those antibiotics, and that's what that's what we call an antibiogram. So the difficulty that it is measured by a lab technician in the lab, and the final interpretation must be done by a microbiologist. And these resources, unfortunately, are not available. An antibiogram this is what it looks like. They're bacteria, and there are antibiotic discs. The white discs are there is antibiotic on them. If the bacteria is sensitive, it does not grow on this culture. If it is resistant, the presence of the antibiotic doesn't disturb it, and it will continue to grow. So the first step to read an antibiogram is to measure the diameters here and to compare them to threshold values from, for example, European or American microbiology societies. And a lot of people think that that's where interpretation stops. Well, we compared 22 millimeter diameter. That is below the threshold of 26, therefore it's resistant. If the diameter is 30, which is higher to the threshold, then it's sensitive, and we consider that the interpretation is over. But no, it's a little bit more complicated than that. There are thousands of rules which give the parallel between what happened in the Petri dish and what happens in vivo in the human's body during treatment. And I often give this example of this antibiogram. There are a number of antibiotics, gentamicin and tetromycin, which were part of the same family of antibiotics. And we can measure the diameters, we compare to target values, and we give this result to the clinician, but it's wrong because the rule for interpretation says that if azithromycin is resistant, even if we see a large diameter in the dish, the probability of therapeutical failure is there, and so we shouldn't use it anyway. So with Antibiogo, it's a very simple tool to try to overcome the lack of microbiologists by using an application which, when we take a photo of the antibiogram, it can do this interpretation. Antibiogo exists now. You don't need an internet connection. It is autonomous. The digital code will be open source, and the idea is to help the lab technicians to interpret antibiograms if there are no antimicrobiologists. It's very simple. You take a photo. The first part is just the image recognition that will help the lab technician to measure the inhibition zones. It's a semi-automatic measurement, and that was very important for us to make sure that the lab technician's own responsibility, they have to improve everything that is identified by the application. Artificial intelligence is only used on that part to identify the names of the antibiotics, because, of course, manufacturers have different codes for different, for amoxicillin, for example, that can have 4 or 5 different names. And therefore, we entered in the model the different brands of antibiotics to suggest the right name to the lab technician, who, of course, remains responsible for approving this measurement and the name of the antibiotic. Then all of this information is sent to an expert clinician. That's the heart of the application. This expert system contains numerous rules for European or American microbiology, and with the input, the expert system applies the rules and gives interpreted results as if it was a microbiologist. We can therefore give a quality result to the clinician. Of course, we have developed a result format that is easy to understand for the clinician, and Antibiogo the first user is the lab technician, but the end purpose is to give a result for the prescription for the clinicians. Therefore, it's important to include the clinician in the loop of the design and development of the application to make sure that the final result will be used in the right way by the physicians. So Antibiogo is a diagnostic test, but as we also wanted to grow the capacity of lab technicians whilst they used Antibiogo, we didn't want to have blind lab technicians who just never question the application. We also developed training tools, so certain interpretation rules can be shown to the user, therefore the user can understand why it went from sensitive to resistant. And as we also want to improve the quality of data, first of all for the patients, but then for surveillance, we developed surveillance functions that shared this data with tools, such as the data collection tool of the WHO and the WHO surveillance system. So we quickly understood that Antibiogo was not just a simple application, but that it was a medical device. And I have a lot of questions, actually, for people who were speaking in the first round table on retinopathy and the questions of regulations, which I'm very interested in, because we very quickly came up against the fact that when an application yielded a result that had an impact on the medical decision, it was considered to be a medical device, and therefore it had to be thought, developed and tested and implemented according to the norms developed by the European Commission with regard to medical devices. And therefore, that's a lot of constraints regarding clinical evaluation. So we carried out clinical evaluations, and this brings us back to the discussion of the roundtable. All of the studies went through national screening in collaboration with the countries and in agreement with them, be it with regard to collection of photographs or the studies themselves. In Mali, there was a pediatric site of the MSF. In Jordan, it is a hospital where we receive people injured in the war with very high resistance. And in Senegal, it was in collaboration with the Pasteur Institute of Dakar, where it was a living lab. The antibiograms were non-routine to look after the patients, and there was another lab technician that took the antibiogram, that read it with Antibiogo and didn't show the results to the lab technician so that we didn't bias their routine tests, and the photos plus the measurement of diameters and interpretations was put onto our server. We took the photos, all of the results of Antibiogo, the antibiotics tested, the measurements, and that was sent to 2 microbiologists who were external to MSF, who'd never worked for MSF, and who did their own interpretations on the basis of the photos and the information on diameter. Then we compared the concordance between the interpretation done by Antibiogo and the interpretation by our 2 microbiologists as gold standards. We obtained a concordance of 90%, and for the 10% of non-concordance, it was interesting to see that when we did a third reading, the majority of the discordance was linked to the microbiologist rather than to the application. We therefore managed to finalize our regulatory file for European approval, and in May of last year, we obtained the CE approval, which showed that the application was developed and tested according to, which guarantees that it gives reliable results for the patient. So for the first time in the history of MSF, MSF is become a legal center for a diagnostics test. Today, we've come a long way because Antibiogo is used routinely in 6 countries: Yemen, Jordan, Mali, FCA, RDC, and we are currently implementing it in Gaza. And since September 2023, we've been working with the Ministry of Health with the objective of equipping all of the ministry's health labs at the national level with Antibiogo by the end of December 2023. When we carried out an analysis, and that is also a regulatory obligation, of antibiotics performance in normal using conditions, we realized that 85% of antibiograms were corrected with this tool, which was not the case when the lab technicians didn't have access to it. So we asked ourselves a lot of questions around AI, and mainly regarding the regulatory aspect of things. We could have developed an algorithm to directly interpret the antibiograms. We decided not to do this. We decided that the expert system, which is an old but very robust technology, and with which we have a lot of hindsight, could respond to this need of interpretation. We used AI rather around the question of recognition of the names of antibiotics and on measuring the diameters, because it is something that facilitates adoption. We realized with the lab technicians that if we ask them to enter the measurements manually, do the measurements and enter it themselves, and then it's the expert system that did the interpretation. It was not something that helped the users to adopt this tool more easily. However, by providing the possibility of having a faster reading, not better because it's semi-automatic measurement, but a faster measurement, and it was more pleasant to use as well. The lab technicians were far more engaged and actually used Antibiogo and the expert system. So, regarding the databases that we used, so these data came from the countries in which Antibiogo is used. That was important for us, that it be in Jordan, Mali, or Senegal. The ethical question is very important. With a lot of ethical committees of the country said, yes, but NADA, we need the patient consent. And the discussion was around, does a bacteria belong to a patient? Because an antibiogram is anonymous data by nature. There is no patient information. There is a list of antibiotics. There are bacteria that have different aspects, but no patient data. And this is a question that has not yet been answered. We're continuing to do our studies. We continue to submit it to ethical committees. Some countries give great examples, and they say that, no, the bacteria cannot be directly linked to a patient, but others remain very attached to the question of enlightened consent, even for bacteria. And the experience in Jordan, for example, showed that when we asked the patients the question, do you agree for us to take a photo of your bacteria? Well, in fact, there was a great deal of suspicion that came about due to the fact that we asked this question, because they didn't understand why we asked such a simple question. The most important thing for them was to have the list of antibiotics that they could take for treatment. And the question of what bacteria and what it looked like, for them, they didn't feel was relevant to ask consent. So regarding the training of the model, we had some great performances. Nevertheless, we realized that the more photos of different sites we added, the performances were still good, but they were variable. And that's what was interesting in the roundtable. It's quite true. Photos taken in Paris, you will no doubt have a model with performances that are close to 100%, but what is the most important is to take photos in real conditions with users who are not professional photographers and who are not used to using sophisticated cameras. In any case, Antibiogo, we asked them to take a photo with a simple smartphone with 10 megapixels, which is the lowest resolution today for smartphones and cameras. We're also working on the question of prototypical federated machine learning. As there are all of these difficulties of data sharing between countries in order to have robust databases, in collaboration with the Polytechnic School of Lausanne, we developed a model that allowed each telephone without an internet connection to learn locally. So if an antibiotic is not detected by the initial model, the user can manually enter the name of this antibiotic, and the next time the application encounters it, the model will have learnt itself with the help of the user. So they won't need to re-enter the name. And this allows us to bring the user into the learning loop. And there is a possibility, well, once the different local telephones have learnt, there is the possibility, once we bring in the internet connection, that this learning be uploaded to the central level for it to be approved and then dispatched back out to all of the other telephones. That is a big regulatory problem because it's a total grey zone on when you send the improved model and not the data to the central level. What happens? You approve it. How does the validation work? And for a medical device that doesn't have the right to change normally, unless you go through regulatory clinical trials, can we send back an improved model? Is it ethical to deprive the users of an improved quality of the model just because there is a lack of regulation? That's where we stand today. We are trying to document all of this so that we can provide our arguments to the European Commission regarding regulations around medical devices. Nevertheless, remains a grey zone. What remains the question of using AI remains very important. Today, with a diagnostic tool, if the artificial intelligence tool delays the marketing and the possibility of treating a patient and acting faster, the question is there. Should we opt for that technology? And is the added value of this technology sufficient for us to take the risk of delaying the marketing? And there's also a regulatory grey zone that is stacking up, but which is changing every day with the legal constraints imposed, new legal constraints imposed upon manufacturers. So maybe we can conclude quickly, Nada Manu. So this was a final example of an algorithm that we developed to identify resistance mechanisms. The model was good, but we realized that by doing this, the lab technician, we didn't ask them the question as to whether they agreed when they saw this type of resistance, this type of synergy, the two photos on the right of the screen. Therefore, we decided not to include this model in the application to avoid removing the responsibility from the user, but rather to develop a design that could support the user in detecting and recognizing this resistance mechanism. So what were the lessons we learnt within MSF and that we are trying to use to develop our diagnosis test? So things such as an algorithm to detect colon cancer. One of the questions we asked was, will artificial intelligence really make the interpretation better or easier? And we realized that given the fact that the expert system was far more robust for that part of the interpretation, when we removed the user from the loop and that we removed the responsibility from them, we realized that that was not the best way of having responsible users who are using tools with this type of technology. Then there's the regulatory question. Is the added value of the technology far more important and worthwhile to take a regulatory risk of complexity and also, the fact of being within this grey zone? And finally, when we looked at the variability of the antibiograms and above all the quality of the antibiograms from different sites and the impact on the model's performance, this confirmed our decision not to use AI for interpretation. And I will end by saying that we're very happy that European regulation and FDA imposes a lot of constraints around medical devices and the use of AI, because we want patients to be able to be treated with quality tools, and quality tools means tools developed ethically and in compliance with norms and standards. But the question today, and this is related to the question of the business model, is for countries with limited resources, how can we guarantee that these tools, these algorithms, will be available to them, but at a reasonable cost for low-income countries? And our experience with AntiBioGo today is that it is the only free medical device available, and we are approached by many companies because they're interested in buying us out or working with us in order to get their hands on AntiBioGo. But the biggest risk for MSF and the MSF Foundation is that this tool would no longer be easily available to limited resource companies. So here I raise the question, AI will continue to evolve, regulation will continue to be increasingly constraining, which is a good thing for patients and for me, because we will bring things to market faster. But how can we guarantee that these devices will be available to populations at a reasonable cost?
Merci.
If there is
Merci
and if
beaucoup,
these
Madame Alou,
labs
on va
will
applaudir
be
pour
ready
cette
to take that
explication,
regulatory risk that we're
sur ce
taking
projet,
today.
cette
Thank you
description
very much for
du
this
projet
project and the description of your AntiBioGo project. And to close this morning's proceedings, as every year, one of these highlights of this event, and that is the 2023 awards. So the first project today is TeleMed, in its development in Kyrgyzstan, and that is a solution that allows GPs, who are sometimes very far away from the doctors, to have access to specialists thanks to their smartphones or tablets. This is a project that is led in partnership with the authorities of Kyrgyzstan and the Indian NGO, and let's look at this project.
In order to access care without telemedicine, the children have to travel distances, sometimes hours, 7, 8 hours, sometimes days to even reach a secondary or tertiary care hospital. Through telemedicine, we aim to bring this care, bring this expertise to their local family doctor. For the primary healthcare doctors, you just need a tablet or a phone and an internet connection. The app also works offline. It's very easy. The family doctors use it in their clinics or during the home visits when they travel. And the specialist whom with they are connected, again, they can just work from their desktop or their phone. The doctors are able to provide these treatment to the children in their villages, in their locality. So it really empowers them and builds their capacity to be able to connect to a specialist, get that expertise at a local level and disseminate it with, to the children and the parents and the caregivers. The telemedicine is not just, like a phone call between a doctor or a patient. It's an entire system of electronic health records. So digitization is what changes in the health care system.
Voilà, très beau projet qu'on peut
Amazing project that we can applaud, and to receive this prize, all three of them came from very far away. First of all, from Kyrgyzstan, and we would like to very warmly thank Vitaly Shumatu, who is with us and who will be coming up on stage, who is the general manager of the e-health center in Kyrgyzstan, and who is with Azizbet Mamat, who is director of the information system for the e-health center.
Je les cherche tous les deux d'images. Venez me rejoindre. Voilà, venez me rejoindre.
Please join us up on stage here.
pour recevoir ce prix.
To receive this award, we can give them a round of applause. So they've traveled here from very, very far away to be with us here today in Lavaur. We will also have Viva Baboon, who's from India and who is Director of Programs with IntelliHealth, and who will be joining us here on stage. Viva, up on stage, please.
Je vous donne aussi également des micros.
I will also be giving you microphones.
Première
To
question.
each of you, the first question
Pour vous,
for you,
avec moi, première
please
question
stay
pour
with
vous,
me.
Vitaly
For you, Vitamishi,
simplement votre sentiment.
what is
d'avoir
your
été ici, d'être venu du
feeling of being here, from coming here from Kyrgyzstan to receive this award? What are your feelings as you receive this prize?
Sorry, can you please repeat?
Yes, I just wanted to ask you what you're feeling today, because you came from Kyrgyzstan here to be here in Lavaur with us, to be awarded and receive this prize. So what's your feeling today?
Good feelings.
Yes, of course. C'est une bonne illustration du théorème. Normalement, on a des courtes questions et des courtes réponses. Là, on est
Normally we have short questions, short answers, and here we went straight to the target. Also, a very simple question. What will this project and system change today for the areas involved in Kyrgyzstan?
This system was implemented in our country in 5 regions, and considering that our country is mountainous, as there are many places are hard to reach, so that solution had an important impact of improving of public access to healthcare.
Est-ce que vous envisagez aujourd'hui d'étendre ce projet
Are you
l'ensemble
intending to extend this project to the entire country?
Yes, we have prepared a document of government where we write an telemedicine service. After this document will be approved by state body, authorized state body. We are going to make a action plan of expand telemedicine services throughout the country.
Viva Baroud, pour vous qui avez
for you who developed this solution in India, we saw in the documentary that you're also present in other countries, in India, in Syria, in the Philippines. Is it necessary to adapt things a lot?
Linguistique, culturel,
processes in each country?
Yes, so each country, each community, they have their own challenges and they have their own access barriers. So it becomes necessary to have a solution that addresses that need. Having said that, it is also important that the technology, there's not so much of customization that it takes months to develop and implement in different places. So what we have done is our technology is architected and designed in such a way that it is very quickly configurable and adaptable to different health conditions, right from NCDs, non-communicable diseases, to infectious diseases, to mother and child care, to different user groups like community health workers, physicians, midwives, and also to local contexts like languages, different health-seeking behaviors, different acceptability in the providers and patients.
Et dans le cas présent, par exemple, pour l'adaptation de votre
And in the present case, the adaptation of your technical solution to Kyrgyzstan, could you just give us 2 or 3 examples of adaptations that were necessary to adapt to the local health system?
In Kyrgyzstan? Sure. So while we were implementing this project in Kyrgyzstan, we had to ensure that the clinical protocols were based on for children with disability. So the Ministry of Health, they developed clinical protocols which were specific to cerebral palsy, neonatal jaundice, and these were then configured into the technology. And we had to bring in the workflows that were integrated with the current health system in Kyrgyzstan, and of course they had to be in the local language, that is Russian. But this configuration, it just takes few weeks to do that. It is not a very long, arduous journey that we start in 1 year and end in another year, and that is why in such short period we have been able to reach 5 regions and are planning to expand soon.
Effectivement, c'est une adaptation qui est extrêmement rapide.
Yes, that's a very fast adaptation in just a few weeks. So in a nutshell, what development opportunities do you have for your technical platform? Do you have other countries that you will be working with?
Yes, we are already working with Syria. We've worked in Philippines, Kyrgyzstan, India. We have multiple projects. I think the world knows the importance of telemedicine, and the COVID pandemic has clearly shown that to all of us. The question is not more towards opportunities, but how fast we can act on it. Because as per our last panel discussion, the technology is growing exponentially, and it is here to stay whether we like it or not. So it becomes our responsibility to ride the wave, make the best of it, and ensure that the healthcare is accessible to those who need it the most.
Félicitations en tout cas, je veux dire.
Congratulations to all three of you for this award. Maybe we can stand up to
Jai Ganesh,
and Jai Ganesh will be joining us up here from the Pierre Fabre Expert Foundation, and above all, Executive Director.
Et je vais vous donner le prix, surtout le plus
So
important.
Bob will give you the award, which is the most important thing, the award that you will be giving
Voilà,
to Telemed KG.
Se lever.
Maybe everybody can stand up
and come next to me.
and come to stand next to me.
Jai, juste en quelques
Jai,
mots,
in
pourquoi
just
ce
a few
choix
words,
de prix
why
pour,
did you
pour
choose to
Telemed
give this project the award?
One of the criteria that we used to evaluate this project was the context why telemedicine is very relevant and important for Kyrgyzstan. Like I think we also listened that it's a mountainous topography and the low population density, and then a part of the population is also on the move, nomads. So I think having brick and mortar facilities everywhere is sort of not possible. And telemedicine, literally standing for the distance medicine, makes a huge relevance. That is one thing. And of course, the support and commitment that the government gave. The Deputy Minister of Health is also in charge of digitalization in the department. And digitalization is one of the 10 strategic areas the government has identified. And then also considering the population of children with disabilities. I think if I remember right, during the evaluation, it was around 1.3% of the children are with disabilities, and that could be prevented. And considering the population of, I think, about just more than 6 million, 6.5 million. So this is huge. And also the patient to the specialist care ratio of 1:18,000. So considering all these scenarios, telemedicine is very relevant for the country. So that was one of the criteria, and of course the support that and the involvement, the political leadership and commitment is also very helpful, because it cannot stop at the pilot. Pilots have to scale, and then without measuring, as you say that, without measuring, it cannot be managed. So I think, and then we hope from the foundation, this support for the project will be used for the evaluation and monitoring of the project, and also further strengthening of the nationwide rollout. I remember one of the requests also came from the Deputy Minister during the evaluation, which our Director of Programs from the foundation was there. And then I think the request was to also link up the identity system in the application along with the identification mechanism, the unique ID identification mechanism in the public health. So that's also a very important means we could see the vision of the country and the relevance. Thank you.
Jai, juste en quelques mots, il y a la remise de ce prix.
Thank you, Jai.
aujourd'hui,
Just
mais
in a
ça
few
ne
words,
s'arrête pas
there
là.
is the award here,
La
but it
Fondation
doesn't stop
va
there.
aussi apporter un
The foundation
soutien
will also
à
be
ce projet.
providing
Qu'est-ce que vous
support
allez
for this
apporter de
project.
manière
What
concrète?
concrete support will you be bringing?
Yeah, I think the support will be more towards the evaluation and monitoring of the project, because that is required to bring in further confidence of other donors and development partners to bring in the funding. I think, if I understand right, there's also this the vision for nationwide rollout. So for that, I think this support is like a seed grant. Consider this as a seed grant that will also bring in other partners. This is not going to be the only one, right? So there are going to be others, and UNICEF is already supporting from what we know. So I think that will be one of the things. And then please, I think, make every effort to make sure that the pilot actually rolls out in scale to as a national telemedicine program.
Merci beaucoup, félicitations. Je vous laisse remettre ce prix.
Thank you very much and congratulations. Please give this award and we will take a few photos.
Et on peut les applaudir.
And we can give them a big round of applause.
Voilà. Allez, un petit coup de flash. Et de portable. Beaucoup de portables. Merci beaucoup.
Thank you very much.
Félicitations.
Congratulations.
Et voilà, please remain with us here on stage while I'm calling the next one. Of course you can.
Thank you. It's truly an honor to receive the Pierre Fabre Otis Award. I would like to thank the Ministry of Health to be a proactive partner to ensure that this reaches to the population that it needs. UNICEF, of course, for laying the foundational bricks, and most importantly, the patients and the physicians who are utilizing the services. Your trust and engagement is the true measure of success. And this award is not just acknowledgement of the achievement, but also a responsibility. So we pledge that we will leverage this honor to further our impact. And thank you, Pierre Fabre Foundation, for your commitment and recognizing our efforts. And together, let's make the world a more equitable and healthier place.
Merci beaucoup, Viba.
Thank you very much,
Vitaly,
Viba.
voulez-vous ajouter quelque
Vitaly,
chose?
would you like to add something?
We agree with WIPA, and we say our thanks for Pierre Fabre Foundation for inviting us, for giving your support, and thank you.
Merci beaucoup. Thank you very much. Please sit here. Le deuxième projet.
Second project under the spotlight today is the PhytoSense project, which is of telemonitoring and from an Indian company, CareNX, which is developing throughout Asia and also Africa. And let's have a look at this project.
PhytoSense basically measures fetal heart rate, then fetal movements, uterine contractions, mother's heart rate. If it is a twin baby, then twin baby's heart rate. We used domain knowledge, clinical expertise, as well as our competency in computer science to develop this algorithm and scoring system, which automatically analyzes the test data and produces the score. Out of these 300,000 patients, 52% of the patients who were into fetal distress have got diagnosed early on. And out of those early identified patients, almost 33% of the patients have escaped from high risk. So this is a remarkable impact that we could achieve just because of proliferation of fetal monitoring.
Voilà, le projet FETO-Sense.
So that's the FETO-Sense project. Let's give them a big round of applause. The 2023 winner for the Pierre Fabre Award. So we have Koukalni, who is co-founder of CareNX. Please join me up on stage here, Aditya.
Et qui est venu avec sa
And
manette,
he came
sa manette
with
FETO-Sense.
his
Voilà,
FETO-Sense
un
case.
micro.
Here's a microphone.
Ok, bah, montrez-nous alors un petit peu.
Let's have a look at what's in your magic case so that we can understand what it contains.
Can you tell us just you have in your magic suitcase here?
Sure. It's a life-saving device, basically. So as you can see, it's a portable technology. Early on, a lot of fetal monitoring devices were available. However, either they would not work on field because of dependence on electricity, wired nature of devices and all that. We removed all those limitations and made it compact so that even a frontline health worker can use. Second, the results that we obtain, earlier doctor used to interpret the result. And there was a lot of subjectivity because the results would get printed on the paper and doctor has to eyeball through it in order to know what is going on with the baby. We removed that limitation using AI so that a frontline health worker can do the test reliably and can understand results there itself. So that decision making becomes very powerful at a ground level and the high-risk patients could be triaged at a tertiary facility early on. So that is the innovation.
Jai insistait il y a quelques instants sur l'importance.
So Jai was underlining the importance of scaling up a few moments ago. We see that this project you've developed in India is now being exported to many countries throughout Asia and Africa. How do you adapt to local specificities?
Sure. One of the questions in terms of scalability of any AI-based solution is about demographic differences. And Professor early on in her talk mentioned that we needed to get data from local country in order to train the model. For us, it was little easier because our data is one-dimensional, not images. It's a trace of fetal heart rate. And we could get global data available openly through a lot of publications early on. So we relied on that data to train the model in local context so that accuracy is maintained. Second, certain localization such as language, such as the operating procedure of the device remains universal because it's a very, like every gynecologist or every frontline and A&M would know how to perform the test. We did not face a lot of problems in terms of training. So that made it simple enough so that they can use it on ground. And technology itself was little simple than images, for say.
Bravo pour ce projet FETO-Sense.
Congratulations for this FETO-Sense project. And Sarah Lesso will be coming up to give this award from the L'Avenir Foundation. Sarah, please come and join us up here. We can give her a round of applause too.
Je vous donne un micro, l'occasion d'ailleurs avant de remettre
So before you give this award, Sarah, you can recall that there is already a partnership between Pierre Fabre and his foundation L'Avenir. Yes, the Fondation L'Avenir supports applied research for the benefit of patients, and we've been doing this for more than 35 years. It was created in 1987 by French Mutual Insurance Association and has supported more than 2,400 projects. Since 2017, Pierre Fabre Foundation and Fondation L'Avenir are partners in a digital fund for promotion of health projects based on digital technology, and we support the prize of the Observatory of e-health in countries of the South to promote the health of the future by learning from experiences in countries of the South. And this year we're very proud to give this award to CareNX, presented here for the Phytosensor project. So what do you like the most about this project? Well, the Avenir Foundation, among the projects supported, wishes to support e-health projects, in particular projects that use artificial intelligence, as underlined on many occasions this morning. It is a precious basis for connected tools that we can then use for as decision-making tools for doctors, physicians, and the Phytosense project is totally aligned with our values. It is a tool that is based on artificial intelligence, and that gives a turnkey solution that reduces mortality among infants in regions with limited resources, and it doesn't require any particular consumables and can be used easily on the ground, and it has already enabled an essential examination to be accessible to the greatest numbers possible by detecting fetal distress and avoiding premature birth. This is the award to give for the Care and X company. Please give this award, and we will take some photos. Give them a big round of applause for this award given to Phytosense, the winner of 2023 of the e-health Observatory in countries of the South.
Oh, pardon. Voilà. C'est comme la médecine, c'est une sorte de précision, la photographie.
It's like a medicine. You need a lot of accuracy when you take photos.
Si, merci à tous les deux.
So thank you to both of you. Please take a seat.
Les quelques dernières minutes.
Just a few minutes before we have lunch, because oh, sorry, I do apologize. Please take the floor.
Sure. So I just wanted a couple of minutes. So first of all, this award is not for me alone or for my company. It's for everyone who has supported my project till now, and 1,000 plus hospitals who are using it on a daily basis. On a daily basis, more than 2,000 pregnant women get screened through Phytosense, and we could actually save lives on field. So I want to give this away to everybody who has contributed to the project. I am merely a representative, but the hard work belongs to them. So for them, I think this award is well deserved. Thank you so much, Foundation, for supporting me.
Merci beaucoup. Please stay with us. Adilkia qui est venu de Bombay, de Mumbai.
So we're going to come from Mumbai to receive this award today. So I was saying we just have a few minutes left before we break for lunch. It's now or never if you have any questions or comments with regard to our nominees, and I would encourage those who are following us remotely, if you have any comments, please do send them to us. We have 2-3 minutes. I don't know if there are any hands being raised in the audience. Any comments, or maybe some congratulations, or
Jai,
Jai,
you're the first one.
This question is to Aditya. So how, what components of, what percent of the components that is you could source it locally, and then also the other thing is how about the support to the kit, is there an annual maintenance contract? Because I've seen telemedicine projects, especially a simple, few dollar adapter, power adapter, can cause the whole program to stop. But this involves a little more. So I was involved in something similar for vital sense telemetry. So this kit will involve some maintenance and then upkeep. So you also have this program built in? That's the question that I have.
That's a very good question. Because even after developing innovation, taking it to customers and on field is a really different challenge, and we learned it through experiences. Because as far as delivery of the product is concerned, the continuous support for the lifetime of the product is very essential. And typically, when we see in medical field, after a while, when it is being used by multiple people on ground, certain aspects which we won't assume early on will come up. And this is exactly what happened with Phytosense early on. The reason why we made it so portable and modular is because even though certain component is not working on field, we could detect it using software, and instead of repairing, we can just dispatch that component itself to the customers. And in that manner, we have developed an annual maintenance system through which you can replace it unlimited amount of time. So for governments especially, they require 5 years of maintenance, and we provide it in the contract, that for next 5 years, even though certain component goes bad, we would be able to detect early on and replace it within 8 days. That is the guarantee that we provide to the customers. When it is about deploying it to other countries, we partner with local device manufacturers who have good network among the doctors, and we actually support them with the supply and everything, so that the service for the end customer doesn't get affected. And this is very good point, because ultimately after a while, new problems and challenges will emerge, which we don't take into consideration early on.
Est-ce qu'il y a d'autres questions, monsieur?
Oui, merci.
Yes, thank you. And I would also like to thank all of the speakers. And I would like to join the others to congratulate you. My question, these are devices that are suited to Asia and elsewhere, but are things the same in Africa? I come from Chad, where I participate in the e-health operation. In our country, a lot of women have cesareans and a lot of women have miscarriages. That's the state of things in our country. So if we have a partner who will support us to unroll these devices in Africa, there is internet problems, connectivity problems. So how can you adapt to a context which is slightly different from Asia? Thank you.
Sure, that's a very good question. Actually, the feeling is both ways, because we also tried to scale it up in other countries, but just because we could not bring partners together or could not have capacity to scale it up, we couldn't do it the faster way. One thing you mentioned about miscarriages and a lot of prematurity. In the video also I mentioned about a study which we have done in order to reduce prematurity. What essentially happens is, when you have such a tool on ground, in order to screen it later on in the month when you expect delivery, you get additional data points in order to prolong delivery. And in the last month itself, even though you prolong it by say 5-6 days, it gives additional time for a fetus to grow in the womb. And that actually does the magic. So our idea is to help doctor take decision on prolonging the delivery, so that number of C-sections will reduce. And that has created an impact in India, and that is evident through our publications. So we want to replicate the same system across Africa, because we understand that the context is similar, even in Southeast Asia. It's just that our organization is small, and that is why we couldn't do that so far. But if we get good network, if we get good supporters, we definitely want to scale it up. So that is the mutual feeling that we share.
Merci beaucoup. Merci à tous.
Thank you very much. Thank you to all of the winners. Congratulations. We can give them another round of applause.
Hop, 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 hop. Ah, il y avait une toute dernière alors. Allez,
there was a final question or comment.
Allez, en deux petites minutes, une
2 minutes.
Question.
Final question.
Merci beaucoup.
Thank you very much.
Je vais faire rapidement.
I will be brief. We are two startup creators. Currently in Africa, we're looking at how to create an ecosystem to encourage the emergence of new startups in the field of e-health. And the questions I always ask startup creators is, what is the decisive moment from the creation, the idea to today, which meant that your startup today is able to scale up or not? Is it somebody you met, somebody you knew? Is it money? What exactly meant that your startup actually has been successful?
So I'll go first. To my experience, none of the metrics matters until and unless your customer is satisfied. And that is the stage we call product market fit, where customers themselves give demands about what extra they want with the product, and tell proactively that they are very happy and this is actually making their lives easy. So that is the checkpoint that we feel is the most important checkpoint in any startup's journey. You can get funding from n number of organizations, you can get n number of recognitions, you can get applauded a lot about research and everything, but until and unless the end beneficiary, the end user testifies it, I think nothing matters. And this has been, so we learn it in a very hard way, because early on it's all about like progressing about your project, But when you get to that stage, I think that is the right point from where you can take off.
Viba, en quelques mots, just in a few words, please.
Yeah, I think I agree, Aditya, with what you said. It's ultimately the health outcomes that matter for us. In our case, are the patients getting better? Are the providers who are using our technology satisfied and are, accepting telemedicine as a form of caregiving? It was, to be honest, pre-COVID, it was difficult for us to, convince providers and patients that telemedicine is, like a form of caregiving. But COVID was a litmus test for us. And since then, there's no looking back. So the change in the ecosystem and the focus on the users, the providers, and the patient is what matters.
Merci beaucoup pour ces explications et sur ce thème passionnant.
Thank you very much for these explanations, and we could have stayed here for hours talking about this very interesting theme, but we're going to have a short break after this first part of the conference of the Observatory of e-Health in the country of the South, but of course our work is not stopping there. This afternoon we will be continuing to talk in particular about ethics and human rights within the scope of artificial intelligence, and you will also discover the other winners of the Observer this year and the position of the World Health Organization on this question. So we will be back here at 2:20 p.m. after the lunch break. So that's. And please keep your headsets for this afternoon.
bonjour à tous et on se retrouve donc pour cette seconde
Hello once
partie de
again,
notre
back for
conférence
the
de
second part of our conference of the Observatory of e-health in the countries of the
C'est au
South.
cœur de nos réflexions depuis ce matin.
The heart
Quel
of our
rôle
reflection
pour améliorer
and
l'accès à la
how
santé. On
do
a
we
vu
improve
beaucoup
access to
concrets
health?
ce
This is
matin
the
de
topic of today. We saw a
projets
lot of
en
concrete
dermatologie, en
examples in
ophtalmologie, comme nos lauréats
dermatology,
cette année. On a
ophthalmology,
déjà vu ce matin
and
beaucoup d'entre eux qui utilisent des
we've
algorithmes
seen many
qui
of the
peuvent
award
s'apparenter
winners
à de
using
l'IA. On a
algorithms
beaucoup
that are
parlé de
similar to
technique,
AI.
mais comme disait
but
Rabelais, science
as
sans
Rabelais
conscience
says,
n'est que ruine de l'âme.
science was only the ruin of the soul. And so with AI, we also need to talk about ethics and human rights, which will we be doing in a few minutes. Beforehand, though, I will cross our fingers that it all works well. We will be going to the campus of the AUF in Abidjan in the Ivory Coast. Abidjan, are you with us? Do you hear us?
Merci beaucoup. Alors, est-ce que vous avez pu suivre
Yes, we hear you very well. Well, thank you. Good. Did you follow the debates of this morning, and what are your reactions and questions about artificial intelligence with regard to the projects presented? So, of course, we've been listening to all of these very interesting conferences. I'm Professor Fatau, and I work in the medical sciences, and I would like to thank you for this initiative and also thank the University Organization for French-Speaking Countries. I wanted above all to talk about what's happening in our sub-Saharan countries in terms of the application of artificial intelligence within the medical sphere. I can give you a very simple example in the field of dermatology. So AI is actually a number of different intelligences that are brought together to establish a diagnosis. And then don't always come from images that we have that are in databases. Most databases are Western databases. For example, if we have an image of a dermatological disease, we have enough databases on particular diseases that can be identified and used so that artificial intelligence can actually be of use for black skin. But then there's a question of the quality of imaging. And I wanted to suggest something. In our sub-Saharan countries, we're extremely interested in artificial intelligence. And we would like support to create specific databases for sub-Saharan populations. And that can help us to build databases that will complement the databases of Western countries. In this manner, we will have a more exhaustive databases that can be of global value and which will be more exhaustive. It is this comment that I wish to bring. I would like to thank you once again for your initiative.
Abidjan de participer.
Thank you very much, Abidjan, for participating. We will be back to you later on with questions, and we hear your suggestion on support to build a database. And this morning we recalled how precious these and essential these databases are for the development of artificial intelligence. And we're going to be talking about this at the roundtable. We're also going to be talking about human rights and ethics in the sphere of artificial intelligence, from the design of algorithms to their use. For this, we will be calling up Aziz Magazine Zoom Kanin Bisek, who is paying us the honor of coming here from Cameroon to participate in this conference. You are head of the Division of Operational Health Research. Please come to my side within the Ministry of Health of Cameroon.
Madame Fazila Sheikh
Mrs. Fazila Sheikh Al-Oudin, you're coming from even further afield. Yes, please give them a round of applause because they've come from very far. Fazila's come from the other side of the planet. You are from Malaysia, where you are a director, State Health Director of Penang State Health Department. So thank you for making this trip to come with us today. Mehdi Snen, who is Chief AI Officer at the IDARE.
Les deux sont bons. D'ailleurs, Mehdi,
and Mehdi, I will give you a microphone. Maybe you can explain in just a nutshell what the IDARE is, IDAIR. Well, it was created just before the pandemic by the current General Assistant Directory of the United Nations. It was a non-profit organization with the ambition of becoming an international organization specialized in research and the promotion of research around artificial intelligence in the field of medicine. So that's a United Nations initiative. And Mr. Labrique, who is the Director of the Department of Digital Health and Innovation in the World Health Organization.
Merci également d'être
Thank you also for being present with us around this table.
Bisek, je me tourne vers vous
and Cécile Bisek, I will turn to you first because Cameroon has an ethics commission and which was recently voted an ethical law. The law was accelerated by the pandemic and a lot of questions raised by patients at that time during the pandemic. And you really wanted to place the spotlight on patient consentment. Why? So first of all, thank you for your invitation. Thank you for raising awareness among governments around this question by inviting us here today, because we will be providing feedback on what we've heard here. So Cameroon in 2022 voted a law on research around human beings, and we did indeed heavily underline everything that has happened in the field of research, particularly in our country, with the question of enhanced traditional medicines. We had to protect patient participation in research. So if I'm to create the link with what we've heard so far today, I must say that we should have developed this more because we considered people, but we didn't consider the data related to this person. And indeed, data management. We took an interest in data sharing. But with everything that we've been hearing since this morning, I understand that a lot remains to be done. So you're saying in this law, you didn't really focus on the questions of artificial intelligence and data within this scope. Why? Well, I don't think that it was such a hot topic at the time. I think that, as somebody said this morning, with the COVID, in our countries, we realized many things. And the law had been studied, of course, well before COVID. And it was put through in a bit of a rush. And we could have. I'm not saying that we missed an opportunity, but there is a need to really take into account all of the different issues around artificial intelligence. So we can say things as they are, because it's the north and in the south, there is no difference there. Science is moving really fast. Artificial intelligence is galloping ahead, and it's not easy for the legislators to keep up with it and to develop laws at the same pace. Indeed. What I've heard today, artificial intelligence, okay, but artificial intelligence for what purpose? If we say that artificial intelligence is there to compensate, because for many, the projects were designed to fill in a gap where there are human resources lacking. So I wonder whether for us as Africans, if we develop AI programs for this purpose, does this mean we have to stop trying to fill that gap in human resources? That is my first question that I ask myself. The second is, what about interpersonal relations between the healthcare professional and the patients? Because I heard one side of the story, but actually I don't quite entirely believe it. I think that the human resource gaps are revealed by the fact that we don't have time to look after our patients, be it here or in our countries. And I don't think that artificial intelligence will actually fill that gap, will be able to replace this interpersonal relationship. So I'm sorry if I'm not quite going along with the others, but I'm not, entirely certain of that aspect. And through this interaction, there is also the question of obtaining enlightened consent. It's not as easy as you might think. And when I have a doubt as to the interpersonal relationship between the healthcare professional and patients, I have a doubt on the facility of obtaining enlightened consent, which is a priority. Oh, no, you're not swimming upstream. This is a space for discussion and exchange, and thank goodness there is a place where we can hold this type of discussion. Fasila Sheikh Aluddin, artificial intelligence is not yet used at large scale in Malaysia, but once again, there are a lot of projects that are developing little by little, a lot of data collection. Can you give us a few examples?
Thank you. Yes, it's not widely used, but of course, there are uses in private and also in public hospitals. But I think since 2016, we had a lot of requests for data, companies from foreign companies and so forth. But at that time, we were not ready to share. And there was no law or policy regarding sharing of data, especially with foreign entities. So, but I think it's COVID has really taught us how important data is and how important AI can be. So we have started a repository under the NIH, 3 repositories: sound, images, and also structured data. For sound, we have started with cough sounds, especially for COVID. In fact, we have launched the app. It's just a pre-screening tool, simple app. You can find it in the store, and it's for COVID. But the data that we used is from our patients, of course with consent, and also data from Koswara, I think it's a database from India, and also from Cambridge. So that's gone live. And right now we are also doing images. So we have done for diabetic retinopathy, and that is already matured. We used, I think, more than 15,000 images, just little less than 20,000, and is ready for deployment. And we'll test it out in 4 primary care clinic and also 2 hospitals. So that we are excited about that. But others are still, we are collecting a lot of data, a lot of cleansing has been done and so forth. For example, for images for TB, lung cancer, and also 12 lesions of lung lesions. And then we have started for skin, for leprosy, and also 8 skin lesions. So that images we have started. And also we have for oral cancer. Has been validated, but right now it's undergoing field tests to make sure it works. That is for oral cancer using a phone for rural areas. So these are some of the things that we have started. Yeah.
Ça, on voit effectivement que les projets, on voit que les projets se multiplient dans de nombreux champs d'application chez vous, que pour développer chaque projet, il nous faut de la data, et essentiellement de la data locale. Alors il y a plein de questions éthiques qui se posent. Parmi l'une des premières questions quasiment éthiques qui m'avait surpris lorsque nous avions préparé cette table ronde, vous me dites que vous avez beaucoup de sociétés, notamment des sociétés américaines, qui viennent vous demander l'accès à ces données. Est-ce que vous pouvez nous en dire un petit peu plus?
Yeah, it's not only American. We had a lot of China companies that came to us. But like I told you, at that time, we don't have how do we share the data? And then what is it for us? And what are you going to use for? So it wasn't clear. So that is why, after the COVID, we went into an open data concept. That is why we are building this repository. So this data can be used. It's all our data, local data. So it can be used by any developers to develop an AI tool. So hopefully there'll be no biasness because it's our data. And Malaysia is a multicultural, multi-ethnic city and so forth. So we are hoping that our data is more inclusive. But we do not really have a specific law yet on AI. In fact, the Minister of Science and Technology is already talking about it in the next 1 or 2 years, perhaps to have a law to say that this technology is AI assisted or even label it as AI generated. So it's an informed thing to the public to use it. So these are the certain things. And also for any research or any request for data, it goes under the Medical Research Ethics Committee. So a lot of questions is asked in that committee. And a lot of it is on data and also on human autonomy. Yeah.
Extrêmement précieux ce que vous nous dites là. Effectivement, la data intéresse, elle intéresse beaucoup de sociétés, qu'elles soient américaines, chinoises, mais aussi européennes, il faut dire les choses. Et si on n'a pas un cadre légal déterminé, il y a déjà des problèmes éthiques qui se posent. Autre élément que vous constatez en Malaisie, mais c'est le cas dans de nombreux autres pays, vous êtes interrogé, pour vous qui êtes responsable de santé publique, par le fait que l'intelligence artificielle semble d'abord se développer beaucoup plus vite dans les établissements de soins privés plutôt que dans le public. Et ça, c'est une véritable interrogation pour vous.
Okay. Yes, I know some of the private sectors are using it, but perhaps because there is no law or regulation, it's easy to use, but it's always in public sector. You have a lot of challenges in deploying and in scaling up. And it's not only just of the technology, but it's also the accept.
Pourquoi pas, si elles sont des règles en faveur des pays du Sud, pourquoi pas. Je vais revenir, mes chers collègues en parlaient un peu du Covid et du trauma du data Covid. Ce qui s'est passé durant le Covid, c'est qu'on a largement encouragé le data sharing. Et après, on a vu que dans les pays du Sud, on a dû faire attendre notre tour pour avoir le vaccin. Et donc, le outcome sharing n'était pas là. Prendre les données, c'était très bien, mais donner les résultats de données n'était pas bien, donc des pays du Nord. Et donc, il y a eu un vrai trauma dans les pays du Sud, et on voit de plus en plus dans les pays africains avec lesquels je travaille, on voit beaucoup de méfiance et une volonté d'écrire leurs propres règles pour ne pas défavoriser leurs recherches, pour ne pas défavoriser l'utilisation de l'IA sur le terrain. Et je pense qu'à un moment ou à un autre, la voix du Sud devra compter, on doit faire entendre notre voix, mais elle est déjà présente. Et je pense que ce qui est valable pour le Grand Nord, ce qui est valable aujourd'hui pour l'Europe, n'est pas valable pour les États-Unis. On a vu la controverse avec le AI Act européen qui ne convenait pas au développement économique au niveau de l'Europe. J'en doute fort que ce genre de réglementation très stricte, très antilibérale, quelque part, favoriserait l'émergence d'un écosystème IA favorable au développement des nouvelles solutions adaptées à l'Afrique.
Que je comprenne bien votre pensée, vous incitez du coup les pays du Sud à avoir leur propre voie de réflexion, leur propre page blanche et se construire quelque part leurs propres règles.
De ce que j'ai pu voir, l'IA, ou la réglementation de l'IA est fortement sollicitée aujourd'hui par les grands leaders de l'IA dans le monde. Donc Microsoft, X ou ex-Twitter et Tesla, OpenAI, Google, c'est eux qui poussent vers la réglementation, mais ils avaient le champ libre pour développer leur propre prototypage, leurs propres produits. Il faut savoir que OpenAI a été développé par une sorte de piraterie sur toutes les données qui sont accessibles sur Internet aujourd'hui gratuitement. Il n'y a pas de copyright sur les images ou les photos d'œuvres d'art qui sont disponibles sur Internet, sur lesquelles tous ces générateurs d'images ont pu se développer librement, sans copyright, sans rien du tout, et qui ne sont même pas référencés par la suite. Aujourd'hui, ils poussent à la réglementation. Je suis assez suspicieux, honnêtement, et je me demande si cette réglementation vers laquelle on veut pousser les gouvernements, y compris les gouvernements du Sud,
the governments and including the governments of the South have been encouraged to undertake won't be an obstacle for development in Africa.
Votre sentiment,
Alain Labrique, I would like to have your feeling on this aspect. Data is gold today in terms of research. We have countries who say that, well, we don't really have a law, either because science is going too fast and we can't keep up with it, or just because we're just at the beginnings. However, we see that there are requests from everywhere because everyone wants our data. So should we create laws quickly or not quickly, copy European regulation that is up and coming? What is your feeling on this matter?
In English first, so everyone can follow as well, but I'll speak slowly. I think governments have a very clear responsibility to protect the health and their populations from exploitation, and to ensure that people receive the care they need when they need it from the health services that are being delivered in the public sector as well as the private sector. They are the enforcers of standards, they are the enforcers of good practice, and I think they are there to ensure quality, to ensure coverage, and to ensure equity. Right? That's the mandate of governments. And democratically elected governments have usually been given that mandate through the electoral process. So I think, whether we're talking about clinical medicine, the practice of healthcare, or artificial intelligence as it relates to health, those same mandates apply. WHO has recently, just a few weeks ago, launched a new regulatory guidance for member states. We serve 194 countries around the world who have asked us to help them to think through what is the building block, as Fazila just said, on which regulatory systems are built. And so, WHO has published a set of guidance around 6 principles which countries should use as the basis for legislation and governance.
Et vous pourriez nous citer, nous en dire plus justement sur ces 6 points de guidance que vous avez édités?
So the first is documentation and transparency. So AI-based systems should be clearly documented. The processes should be as transparent as possible so that national regulators can understand how the outcomes are being derived and what is the process through which that's happening. The second is to have clear risk management planning. So whoever is responsible for the development of the AI tools are also responsible for developing risk management plans based on what the AI is doing. And I'll get to that in just a moment when we talk about a risk-based approach. The intended use of the AI should be clearly expressed. And there should be validation, as many of the speakers this morning, as well as our 2 colleagues have pointed out. There should be some process by which an AI-based tool, just as any other clinical tool, is evaluated for its efficacy. There also has to be data quality. The fourth point is data quality. What is the data being produced by these systems, and is it of a sufficient quality? What are the error rates? Other things that are being developed by the systems. And then, of course, standard things like privacy and data protection. Where is the data being stored? Who is getting access to the data? Is the data being shared to parent companies that are located outside of the country with permission or without permission from the patients and the national regulatory authorities? And then lastly, engagement and collaboration. So one of the key factors of success, I think, is that companies, and you heard this morning from our colleague at Google, companies are by and large willing to work with the government, to work with the regulatory agents to understand what are the rules of engagement. How do we develop a product that can be used in this country according to the rule of law within the boundaries of the national regulatory environment? So I think, so far we've seen an outpouring of goodwill, an outpouring of collaboration between public and private sector, and hopefully, that will continue. But the short answer to your question is government has the role, the responsibility, and the mandate to protect its citizens from exploitation and abuse.
Je rebondis justement sur ce que vous me dites, les gouvernements ont le rôle, le devoir de protéger les citoyens et les data derrière. J'entends les points de méthodologie, de guidance que vous mettez en place à disposition des gouvernements, nord comme sud, qui sont en train de légiférer sur l'IA. Néanmoins, je ne peux m'empêcher de poser la question, quand vous dites que les gouvernements ont le devoir et même le pouvoir quelque part de le faire, est-ce si vrai que ça, sachant qu'aujourd'hui les grands donneurs d'ordre, et vous les avez cités tout à l'heure, sont du Nord et particulièrement américains. Là où on a vu ce matin avec Google, on a une excellence en termes de chercheurs. Les clouds, les outils sont développés dans le Nord. La formation extrêmement développée dans le Nord. Est-ce que les gouvernements peuvent vraiment y faire quelque chose? Et est-ce qu'on n'est pas, avec l'intelligence artificielle, en train de creuser un nouveau fossé, un nouveau gap entre le sud et le nord? Et je vous poserai bien sûr, mesdames, la question dans la foulée. Mais Alain Labrique tout d'abord.
Yeah. It's a really good question. And I think first and foremost, we have to keep in mind, I made a comment earlier about the importance of nuance. And when we talk about AI, it's not a monolith. There's not one big thing called AI. I was talking with our colleague here earlier today that we're talking about elephants, giraffes, and hippopotamuses, right? And if you treat a giraffe like a hippopotamus, you're in trouble because one is a much more dangerous creature than the other. For many years now, we have had machine learning and AI-based software that is addressing serious issues that countries in the global south and in the north have with a workforce shortage, with access to qualified laboratory technicians, with extended waiting times for test results, as we heard by several people this morning. And those lead to adverse health outcomes. So there is a big difference between a learning AI that's constantly changing and is dynamic from a fixed AI that has been trained on a certain data set and that can do a job that it's given to do very, very well. And whether it's in diagnostic imaging or diagnostic radiology, reading breast cancer screens, reading tuberculosis scans or x-rays, reading antimicrobial resistance plates, these are functions that, once you train the AI and you say, okay, you've been trained, your performance meets certain standards, we can now unleash you as a software, as a medical device. It's a very different animal from something that will continue to learn, continue to evolve. And so I think the legislative burden on country governments is very different depending on which of the two animals you're talking about. You can legislate for giraffes, that won't be the same legislation for a hippopotamus. And I think you have to keep that in mind.
Fazila Chekaloudine, j'ai envie de vous poser tout de même la même question, et Médecins l'a rappelé avec beaucoup d'acuité. L'intelligence artificielle permet d'accélérer aujourd'hui les phénomènes. On a parlé ce matin de cet antibiotique, et ce ne sera pas le seul découvert par l'intelligence artificielle. Elle a contribué à créer des vaccins du Covid très très rapidement, en améliorant les puissances de calcul, en faisant des vaccins, mais qui ont d'abord servi le Nord avant d'aller servir le Sud. Est-ce que votre sentiment est que cette intelligence artificielle n'est pas en train de creuser le fossé de manière encore plus importante entre Nord et Sud?
Actually, COVID itself has shown that there is a huge gap between not only within North and South, but also within the country, between rural and urban. Yeah, definitely there's a huge gap. But I think that's why it's very important agencies like WHO or global agencies to help countries to come up with building blocks to develop their own policies or regulations. And but government really has the big role in governance, in stewardship, and also making sure whatever is used for its people is safe and it's of quality. So I think, yes, I agree that government has a huge role in this and is responsible for coming up with policies.
Alain Labrique, rapidement, puis Anne-Cécile Bissek pourra s'exprimer.
I just wanted to even challenge your idea of the chasm. There is a digital divide. There is a chasm of care that COVID has really brought to the forefront. But there are also legacy systems that are holding back many countries in the global north from accelerating their digital revolution in the way in which we're seeing happen across the global south. So someone said today in the morning that we may even see a disparity growing in the opposite direction, where things that have been now developed and launched in countries, India, in Malaysia, in Tunisia, that are not being done in Europe, and where people are benefiting from these systems and this infrastructure that isn't available in parts of the world where traditionally they have been ahead of the curve. So it may be flipping the balance.
But sorry, I just like to add, but I agree to that, because I think the high-income nations, they're bogged down with regulations because they're already matured in that. But in fact, during COVID, we saw Vietnam and Laos, far ahead because there's no legacy, there's nothing to hold them back. So actually, that's what we saw also.
Anne-Cécile Bissek, rapidement aussi sur cette question, est-ce que dans vos gouvernements, il n'y a pas la crainte quand même, lorsque l'on voit que tous les outils, notamment d'intelligence artificielle, sont majoritairement développés dans le Nord, la crainte d'un fossé qui se creuse?
Oui, certainement, il y a un fossé, que ce soit en termes de qui est capable de manipuler, qui est capable de comprendre même comment ces outils sont développés, même si les pays du Nord venaient les associer. Est-ce que nous avons forcément des gens qui ont les compétences pour comprendre? Mais je pense que les gouvernements au Sud ont des priorités. Ils ont des priorités. Nous sommes tous en train de courir vers la couverture santé universelle. On sait par quel bout on doit commencer. Et je pense qu'il faut qu'on commence par là pour voir en quoi cette intelligence artificielle peut réellement nous apporter quelque chose par rapport à nos priorités. Si le VIH est une priorité, comment est-ce qu'on fait pour qu'on délègue des tâches jusqu'au centre de santé le plus éloigné, etc., etc. Donc, je pense que si on prend cette voie-là, on ne va pas se laisser emporter dans un tourbillon d'intelligence universelle sur tout et sur rien.
Médecins, on parle de Sud, mais il n'y a pas un Sud, il y a des Suds. Et en matière d'intelligence artificielle, là aussi, on peut voir, rien que sur le continent africain par exemple, des disparités assez importantes qui commencent à apparaître.
Ça vient juste d'être cité des Suds. Chaque pays a sa propre réalité et le Sud est complètement différent du Nord. On n'a pas encore une cohésion Sud-Sud qui existe telle qu'on peut avoir dans le Nord. Et on est dans chacun a sa priorité, chacun ses besoins.
On a des pays qui investissent dans le Sud aussi énormément dans l'intelligence artificielle. On peut peut-être les citer et justement voir peut-être les disparités qui apparaissent.
Bien sûr, il y a l'Afrique du Sud, il y a le Nigeria, il y a le Kenya, il y a l'Égypte, il y a l'Inde. Il y a beaucoup de pays qui investissent énormément dans l'intelligence artificielle et misent sur l'intelligence artificielle pour l'Universal Health Coverage, pour faire de l'evidence-based medicine, pour accélérer, améliorer l'accès aux soins, primary healthcare au moins, et pour accélérer la phase de diagnostic et pour vraiment combler le retard qu'on a enregistré pour les objectifs 2030. Et donc, mais le problème, c'est que maintenant, si on regarde le Sud comme un ensemble, il y a un gros problème. Le Sud n'est pas un grand... Le Sud, c'est un ensemble de pays différents, avec différentes caractéristiques et différentes priorités. Et on ne peut pas leur parler d'une voie unique et unifiée en disant voici, l'IA va résoudre vos problèmes. Ce n'est pas vrai. Certains pays, certes, ont trouvé le chemin, d'autres cherchent le chemin, et l'IA ne peut pas être une solution universelle à tous les pays du Sud.
D'autant que certaines utilisations d'IA dans le Sud vont avoir des buts relativement différents de ceux qu'on va pouvoir trouver en Europe ou aux États-Unis. On a parlé beaucoup ce matin de médecine individualisée, hein, on l'a vu dans le propos introductif, le bon médicament, la bonne personne en tenant compte de ses gènes, de son environnement, etc. Vous dites dans ce que vous constatez aujourd'hui, ce n'est pas forcément la priorité aujourd'hui dans les pays du Sud, mais l'IA peut servir à d'autres choses, et pourquoi pas en santé publique.
C'est exactement ça. On est aux soins primary healthcare, je pense, au niveau du Sud. Pensez comment l'IA peut optimiser l'accès aux soins, améliorer la rapidité du diagnostic et l'intervention, la planification des ressources, des soins. Et ça, c'est des public health, plutôt que ce qu'on voit en Europe où l'IA est largement utilisée en immunothérapie, en soins precise medicine pour le traitement du cancer. Donc on est sur des priorités complètement différentes. Et je pense qu'à chaque terrain, sa réalité, il faut qu'on s'adapte, nous, à voir, en tant que chercheur, malgré que je suis du Sud, aujourd'hui je suis opérationnel au Nord, qu'on adapte notre modèle de pensée, notre modèle de réflexion et nos recherches à la priorité et
Reflection
pas juste
and serve our priorities. And so we don't just go to the south to grab their data for our own research, for research on immunotherapy, instead of seeing the reality in the field and adapting our reflection to what is needed in the south. So you're saying don't go to the south just to grab their data, and we can't either want to just copy-paste what happens in one country to copy and paste it to another. With EDA, you have extremely concrete projects in the countries of the south, mostly. Can you give us some examples of your type of projects? We're currently working with the African Population Health Research Centre based in Kenya on predictive studies on the evolution of diabetes in a post-COVID population, because we saw what happened. There is a certain correlation. So we're trying to develop AI tools that uses data to help to plan evidence-based policies and resource allocation by estimating the proportion of the population that will probably develop diabetes using AI tools. I'm going to stop on what you're saying because it's important and very representative of what we're doing, and this will so we can use this for diabetic patients in the north and find exactly for this patient how we can help that patient. But you're developing AI to plan the number of potential diabetic patients we will have in the coming years. Yes, indeed. We're trying to give greater clarity to the data we have today to allow public health systems that are more targeted and faster, so that we can anticipate the problem before it actually comes about, so that the resources are already allocated and on site. Do you have any other examples of this type? We worked with a number of other countries, for example, patient-reported outcome monitoring data, and how to integrate this feedback from the patient within a standard patient circuit in hospitals. And we're doing this in India for the treatment of cancer in order to prevent, it's not for immunotherapy, not at all, but it is to prevent side effects within this population, but also detect new trends in the treatment of cancer and the response to this treatment in India. One of your branches of action is training around AI, training and awareness training among healthcare professionals. What type of actions do you undertake? We have just closed a training in Chile for the staff from the Ministry of Public Health in Chile, but also in Latin America. We had 200 participants to raise awareness as to AI and digital health, and we're continuing to undertake operations in partnership with a number of ministries in the Greater South to set up one-off intensive training courses, but which we hope will bear their fruit. And what about the idea of a common governance for AI, which is specific to the needs of the countries of the South? Well, that was a call that was launched at the United Nations and in the greatest multilateral organizations to set up the guardrails and a certain form of common governance. I think it's very important for everybody to come together around the table. It is a problem that is just as acute as that of nuclear weapons, because it represents a risk to mankind or humankind. We can't hide from that fact. But there are many benefits today brought by AI, and we need to all come together around the table, and it should be a governance resolution that is dynamic or that adapts to each country and the needs of each country. Alain Labrique, can you comment on what was just said? First of all, AI applications, we can't just do copy and pasting from one country to another. And it's true that for public health application, that's yet another pathway. And in the future, could countries of the South have their own governance, their own ethics that might be different from ours?
That is different might not be necessary. I think, as I mentioned earlier, there are some core building blocks that we all share as a human family. But I think the core lies in one thing that Mehdi just said is training and capacity building. Right? This is something that groups like IDARE have been aggressively doing. WHO has an AI training program with more than 16,000 people have taken the training program to date. We have a Planning National Digital Health Systems course that many thousand policymakers have taken to date. So it's really about building the local capacity. And I think when we talk about heterogeneity in the South, we have to acknowledge that there are countries in Africa, countries in Asia, in South America that are very advanced when it comes to developing technologies, developing hardware, software, AI regulatory environments, sandbox. I hate to pull out specific countries, but Rwanda is certainly a case study that we're all looking at to see how. When I met the Minister of ICT a few days ago, one of the Global North ministers was asking her, what's your justification for using digital in Rwanda? And she looked very surprised, and she said, well, that's a strange question, because for the last 10 years, digital is the way we do business in Rwanda. So the question we ask is not why do digital, it's why not do digital, right? So I think some of the challenges that we face are really in recognizing the diversity, recognizing the heterogeneity, and the South-South collaborations that are emerging. We're seeing a lot of partnerships between governments in India. You brought up, for example, Mehdi, India providing technical support and assistance to countries in Africa, South Africa providing assistance to regional countries, East Africa providing assistance to West Africa, right? So there's a rich dialogue, conversation happening, and I think right now we're in an inflection point. So things may seem very dynamic and messy, but I assure you that there's a light at the end of the tunnel.
Ouais. Et justement, pour voir cette lumière au bout du
So indeed, to see this light of the tunnel, for you who has a global view of things, because for a number of months, for the past 7 or 8 months, AI is appearing in everybody's life, even in a stronger manner. So there's people are really afraid about employment. There are jobs that seem to be at threat due to AI. So in the north, there is a lot of fear, a lot of tension. For example, the European Commission wants to even more strongly regulate AI. A lot of physicians in the medical sphere, the debates are, very strong between the pro-AIs and the really anti-AIs who will not touch it in their life. You have a global vision of things and you travel around the planet. Do you see a real difference between the north, although there is tension there, and the south, for whom the AI brings more hope, especially for public policies?
I come back to your point earlier, Madam, that there are priorities in the global south that my ministries and governments have been tasked with. I always come back to this question that every 2 days, a Boeing 747 filled with pregnant women and new moms crashes. Every 2 days. And yet it doesn't make the headline news, it doesn't make the sensation. Instead, we're busy, fighting in the halls of power about the end of life as we know it because of generative AI. So without being too cynical, I think there are big fish to fry, as they say in English. There are big problems that we're trying to solve. And if our health workers, so we did a study in Bangladesh where we calculated the burden of a frontline health worker to do the work that she was assigned to do, she would have to work 212 hours a day, which, I'm not a mathematician, but that's a very simple formula, right?
Parler au pays des 35 heures quand même. Hein?
Mais par jour, 212 heures par jour. So, we've given these health workers impossible tasks. So if we can leverage technology, whether it's fixed AI or dynamic AI, but well-regulated, carefully developed technologies that can free up the time that our health workers are spending filling in paperwork, not for themselves, not for the clients, but for the donor who has paid for the health program, right? Then maybe we can improve that formula so that those health workers can actually be providing care at the front lines. Those health workers can be immunizing children against preventable diseases, right? So I think the first set of questions we have to ask ourselves, and that's what we're seeing happen, why this passion about AI is because it offers the potential to solve some very immediate problems. Because by the time we train a new army of health workers, it will be years. And those planes continue to crash. So, I come from a background of public health. I can't sleep at night because I see those planes crashing, and I wonder, what are we doing about it? So we can sit and wring our hands and say, the risk or the terrifying dystopian future that we can imagine is too much to bear. But I think we have the responsibility to act wisely, and to use our collective wisdom to regulate this in a smart way.
Merci beaucoup, Alain Brick, pour ces propos, et on voit comment dans cette
Thank you very much, Alain Brick, for these words. And we can see how this round table, we set off from ethics, and 6 or 7 years ago we would have just talked about ethics, and today we can see how AI has completely disrupted this debate on accessibility, utility, the risk of a fracture, not only north-south, but south-south, or north-north, moreover, and the possibility and the hopes that AI is bringing us. I would like us maybe to take a few minutes to take questions for our speakers. So we will be a microphone in the room, and we have the first questions from the net. So let us turn towards Abidjan to begin with, where you're listening to us from the campus of the IUF. If you're still with us, and I'm sure that you have questions, comments to make after this round table.
Alors, je ne sais pas si on a retrouvé, perdu Abidjan.
Do we have Abidjan online?
La liaison.
Well, whilst we're connecting with them, we have a lot of questions from the internet. The first is for Fadzila. This is a question from James, and who is asking, how can we have a prospective approach for the regulation of areas that are developing very fast, such as AI? I think that this is the approach of Malaysia, because you're preparing even prior to this future regulations.
Well, first, like I told you, we don't have a law or specific law. So what we do is we see what is happening in the other parts of the world, but at the same time, we are also doing a lot of this work. It's actually, we ourselves are testing this out, collecting data and how do we share about it and so forth. So I think it's good that we don't have anything yet, and we learn together with everyone else, and how to come with the best approach. And of course, we also depend on WHO in their building blocks, and a lot of things we can do with our neighboring countries, and also. We have in ASEAN, in Southeast Asia, we have an ASEAN of 10 countries. So there's a lot of sharing of information and sharing of laws and policies that can be done. So that's how we are going in a slow manner, yes.
Merci pour cette réponse. Alors, il y a peut-être des mains qui vont se lever dans la
Thank you
salle,
for this answer. Whilst waiting for the microphone, hello to Abdoulaye, who's watching us from Senegal, who's saying hello from Senegal. Also Benazir, who's watching in Chad, and who thanks everybody for their very interesting debates. Sir, please don't forget to introduce yourself so we know who you are, and then ask your question. Thank you very much. I'm Simon Boni from the Ivory Coast, of the Côte d'Ivoire. I always find these roundtables very interesting. And Alain Lebric earlier on was talking about this support and capacity building provided by the WHO in direction to different participants. He said that 16,000 people had been trained. I would like to have more information on the target public for this training. Are the regulation departments of the countries concerned? Can you give us some more details on that, please? You're going to have a very long list of people who wants to participate in your training.
I'll be very happy to share with you the link to join, but the multiple targets, we're looking at primarily right now training the policymakers. So that's the first target. So policymakers, government officials, folks who are in the difficult position of making decisions about what to do in the realm of digital health planning, architecture, selecting good ideas from not so good ideas. That if you can imagine, many ministries of health have a long line of vendors outside trying to sell the next solution to all of the ministers' problems. So it's really giving that basic understanding of what are the questions that need to be asked about the efficacy, about the privacy, safety, et cetera, of these systems. So I'll be happy to share the links and through the Fondation to the training that's available in French and English and I think Spanish and Portuguese on AI, but also on planning national digital health systems.
Peut-être que Mehdi peut compléter également aussi, parce que vous avez beaucoup.
Maybe Mehdi could add to this, because you do a lot of training as well, maybe targeting different audiences. So far, we have really been working with public health officers and policymakers, and we are hoping to extend our training above all to future generations, so to students who are in the last school of final year of medical studies and pharmacy studies, to equip them with at least a minimum understanding of AI, to avoid them surfing on the market without any understanding of what AI actually is. A question from a web server here. What is the right scale for regulation? Because it's a bit like what the President of the European Commission was saying. Could we envisage a global group like the IPCC in the field of AI, or is this an impossible dream?
Je pense qu'on est vraiment
Well, a quick answer. I don't think anybody really knows. We're trying to find our way. We're experimenting. There is no visibility. AI is changing. We don't know when we're going to, where we're going to land. We don't know what the future holds. Therefore, we're trying to find our way. But it's now or never that we need to all come and speak to each other and adopt a common vision.
Alain Brique, rapidement.
No, I think you know, there are some interagency groups, task forces that are being developed across multiple UN agencies, and that includes government bodies, to try and bring some centralized discussion. But as Mehdi points out, you know, we're far from having a coordinated body.
Autre question dans la salle. Ah, pardon, monsieur.
So another question from the room.
Merci.
Thank you very much, Alain, and thank you to the other speakers. I would like to know.
Je voudrais savoir, nous avons été notifiés par l'OMSPI
We were
qu'il y a une opportunité.
notified that there is an opportunity to obtain support for telemedicine and virtual healthcare.
Sur cette notification.
So with regard to this notification, the OMSP said that there was 2 documents developed by the WHO and another organization, and for virtual healthcare. You're working in the Geneva offices. How can you support us? Because in Chad we haven't yet used artificial intelligence. So as the WHO Health is offering us this opportunity, how can we use this integrate this in Central Africa so that we can begin to use many of the tools that will be available soon for telemedicine?
And you know, as I mentioned earlier, the important question is to first say, what are the problems that you are trying to solve? And what are the priorities of the Ministry of Health and the country? Let's focus on identifying the list of problems and then going and finding the correct solutions for those problems. Some of the solutions may be technologic, some of them may involve telemedicine or AI, but some of them may be more health system strengthening approaches that need to be done. WHO has formal guidelines which are directed at ministries of health for 10 different digital health strategies that are evidence-based and that have solid, robust backing of science. But we still are working on the realm of AI to identify where the recommendations should be for the use of AI, whether in diagnostic imaging or whether in optimizing supply chains or workforce. So bear with us, stay tuned. It's important when those recommendations are made that they're made based on robust, credible, valid science. And that's the role that WHO plays in service to countries.
Je voudrais qu'on parte à Abidjan. Je sais qu'on nous entend.
So let's go off to Abidjan. I know that they are listening to us closely. And I would like to give the floor to our friends from Abidjan who are listening to us so that they can also ask their question.
Alors, voilà, prenez le micro. Voilà, allez-y, on vous écoute.
We are delighted to be with you here and to hear the different panelists. In our sub-Saharan regions, AI is very important. We have a lack of human resources, and if we can manage to use artificial intelligence, it will facilitate many things for us. And earlier on, we talked about the World Health Organization. And there is a lot of support required in this area. In the South Saharan region, there is an activation and the implementation to produce their own data. And in areas such as dermatology, because of course colored skin colors are different, and there are also other aspects. I want the WHO to remember that we first and foremost need reliable data from these regions so that this data can correct the gaps that we can already see, and so that our data is added to the Western data, and so that it can benefit to the entire world.
Merci. Merci beaucoup pour cette question.
Thank you very much for asking this question. I'm going to ask this question to Alain Labrique, because he is the WHO voice for this afternoon. So if I summarize things, maybe WHO has, could you be a third party of trust who we can give our data to and distribute it according to needs, or is this beyond the scope of the WHO?
Good question. I don't think at the moment WHO is prepared to serve as the repository for data. Where as a norms and standards agency, where we can play a role is in helping to curate libraries of training data. And as we heard earlier today, this idea that garbage in, garbage out, right? Same thing applies for AI. If your training data isn't of the highest quality, if it isn't representative, if there's not equity in the diversity of how the data is capturing all of humanity, the models end up as biased. So I think we're interested in pursuing that potential idea, but right now that hasn't been proposed by our member states. And so we do what the member states recommend to us, and so that might be something for our colleagues to propose to their through the governing bodies, that WHO needs to do this, and then we will take that on as a task. If I can just say one last word, I know we're running out of time, but there's a phrase from I think Voltaire, right? Le mieux c'est l'ennemi du bien, and I think what do you say? Perfection is the enemy of the good in English, and I think we sometimes, when we look at the statistics that were shared in the morning, the performance of some of these AI models is phenomenal. But for some reason, we like to set a bar that's much higher for technology than our own people. Mm-hmm. So if people perform at a 50 or 60% accuracy, we're okay with that. But if an AI performs at 75 or 80% accuracy, somehow we want them to do better. So I think we need to examine a little bit the benchmark that we set for our technology to be better than ourselves.
Vous voyez, c'est pas l'éthique à Nicomaque, c'est l'éthique à Lavaur ce soir. On est passé de Rabelais à
we've gone from Rabelais to Voltaire on the subject of ethics from the beginning to the end of this roundtable. Thank you very much to all of our speakers on this roundtable. There are still a lot of questions in the room. We could have stayed here for hours. But Alain Labrique will come back later on to close today's proceedings. Thank you. Please do go back to your seats. And now we are going to continue our conference immediately of the Observatory of eHealth with the 2023 awards.
Et c'est l'Afrique qui est à l'honneur pour le prix suivant.
Africa is our guest of honor with an application created in Senegal to allow young women, men and women to understand the menstrual cycle in women. It's not always easy to talk about this in different countries. And if young girls have not been told what would happen, they don't understand what's happening to them. And boys, when they're teenagers, will come and make fun of them. So WeWe is a tool that has been created to help to build awareness around the menstrual cycle. And let's look at the pictures.
Peu d'espace pour en parler. Donc c'est pour ça en partie qu'on a créé les outils WeWe. Where We, c'est tout un univers, en fait. Donc, on est parti d'une application mobile pour accompagner les jeunes filles et les femmes dans la découverte et le suivi du cycle menstruel. On a aussi un chatbot qui permet de répondre à toutes les questions des jeunes filles 24 heures sur 24. On a aussi accès à un call center de sages-femmes en ligne. Et puis, on a la possibilité surtout de suivre son site. Ça, c'est assez rare dans ce qui existe habituellement en Afrique. On a beaucoup d'informations, de sensibilisation, mais on n'a pas beaucoup de personnalisation.
I'm ashamed of going to school. What have you done? I had my period and everybody's making fun of me. What?
Where We, c'est aussi une super série sur YouTube qui parle aux jeunes filles, mais aussi à tout leur entourage.
Une chose qu'il faut savoir, les filles comme les garçons, on ne se moque pas d'une fille quand elle est tachée.
Amina, je suis désolé.
Pas grave, on oublie. L'enjeu, c'est aussi d'aller en Côte d'Ivoire, au Bénin, au Togo, dans tous les pays francophones finalement d'Afrique et de pouvoir faire voyager nos personnages. Alors rendez-vous le 28 septembre pour la remise des prix d'Odès pour en savoir plus et puis pour se rencontrer.
Et le 28 septembre, on y est, on peut applaudir Marina Gning.
So, Marina Gning, who has travelled here from Dakar, please join us up here. She is the co-founder and director of Happy Africa, who has developed Where We. Here, Marina, this is a microphone for you. And so you can talk to us about this wonderful application, the idea of the web series. So how did the Where We project come to life? Because you didn't necessarily have the intention of, engaging in educational activities. Yes, of course, little by little. Like many big projects. First of all, we created a company in Senegal which manufactures washable sanitary pads and nappies for children. And as I said in the video, there was not a lot of space to talk about it. And that's why little by little we developed the program at the beginning with zero funds and little by little with some partners. And this is how far we've come. So there's also an algorithm to help women with their periods. But before talking about the algorithm, I would like you to talk to you about the construction of the website. So we talk a lot about engineers and techniques. And AI, but you remind us that there are human beings behind this. And this application was actually co-built with the young women and also some young men from Senegal. Can you tell us how you did all of this? Well, it's only co-construction and partnership because I am not a technological expert at all, and I didn't know anything about AI. I've learned a bit about it now. But it set off from a need, and therefore there was a consortium of companies in Senegal. There are 5 companies who've worked together to create these tools. And I think that this is what makes their strength today. There is one company worked on theory of change, measurement, evaluation, and literature review. Another company worked on the user experience and human design. We have another company who worked on the chatbot with artificial intelligence. We worked on the content because we had experience in the field with the young women and communication. And our company developed the application and the website. And indeed, we co-constructed everything with the girls. I'm not the target, as you can imagine.
On a vraiment eu des focus groups
we organized focus groups with young girls and mothers. So the girls came, the mothers came, and they said, I want this, I want that.
Un premier petit livret qu'on avait fait.
We had a booklet that we created 3-4 years ago, and that was the first basis with which we could talk to them. And we identified what shocked them, what they wanted to see. Then we had focus groups on the application with a human design system and a lot of cards to choose the functions they wanted and the colors. I would have chosen pink, for example, but they all wanted pink. It's the Barbie phenomenon there. So the idea was that every time we had a new idea, it's tested in the field to see if it's relevant for our users. So the novelty, it's not just an application to explain what the menstrual cycle is and all about periods. We have the AI to tailor things so that the young girl can plan when she will get her periods and understand her body. Yes. What is specific is that this theme of menstrual cycles is dealt with in NGOs, in the sexual reproduction lessons. But all women have menstrual cycle, whether they're sexually active or not, whether they're mothers or not. And so we focused on that, and we even put a personal development side of things. So real tailored support of the young girl through her menstrual cycle. So of course she will know when she will next have her period, when she is fertile, but we will also give her recommendation for each phase of her menstrual cycle. In this phase, you're more creative. In this phase, you need to stay alone a little bit. In that phase, you have a lot of energy. Now's the time to communicate. So we're really, helping the young girls to come to terms with their own bodies and for their well-being. A final word, because it's important, it's not a gadget. On the YouTube web series, we saw a few extracts in the short video on Where We. First of all, 1 million people have watched the video, and as you say, this contributes to the success of the application itself. It's maybe something that will attract young girls towards your application, and that's important. It's not just technology, it's communication and popular general public communication. Yes, what's really important with this program is that it's multi-channel. There are tools that resonate with each other. It's the same environment. You have this booklet, which for girls of 10 to 15 years old who don't yet have access to the web, no smartphone. You have the mobile app, you have the chatbot, you have the series. We also hold face-to-face workshops. All of this with the same character. There's a story. We find the characters in the series, which targets teenagers. And it's the partnership which led us to success. We worked with a Senegalese well-known producer and screenwriter who is very familiar with the life of young girls in Senegal, and she is the one who created the series. So we co-built the series together, and this is how, with our small episodes and little means, we have a lot of people who've watched a lot of watches and a lot of reactions. Yes, we insist on multi-channel communication. It's very important. Paper communication is not dead, and YouTube is tremendous. If you're not on YouTube, you can go onto Facebook or Instagram or TikTok. Yes, and this allows us to reach out to different populations because the application is focused on young women and girls, whereas the series reaches out to the fathers, teachers, husbands, and we try to go through the series to speak about this theme to everybody so that people can understand. And digital is tremendous, but the impact is very individual. And we're working also towards, from this individual impact, to see how we can broaden this out and we can manage to do this thanks to this panel of tools, this variety of tools, because it allows people to talk about it together. The booklets are often used for mothers to talk with their daughters, the series with the teachers in the classrooms, etc.
Pour remettre ce prix à ce projet qui est enthousiasmant.
So to give this award to this very exciting project, I call Professor Shikayuko, who is from the group of experts of the Pierre Fabre Foundation. Thank you.
Professeur Shikayuko, je vous donne le prix. Je vais également vous donner un petit un micro. Et cette question, qu'est-ce qui a séduit finalement le groupe d'experts?
So what attracted your attention of the group of experts in this project?
Beaucoup de réponses déjà.
Oh, and I think that all of the answers are in what she's just said, and I think that inclusivity is part of the very DNA of the Pierre Fabre Foundation and our e-health project also. We find this a very inclusive project with a very inclusive approach. And we can see that it is a subject that is taboo not only in Senegal, but in the African context. And we talk a lot about co-construction in many projects, except that when you set up this type of project, we don't necessarily see it. But here we can see real co-construction with the beneficiaries who are at the very heart of this. And we say that when we educate a boy, we educate a person, but when we educate a girl, we educate an entire nation. Wonderful philosophy. Final short question. We are giving you this award today, but things don't stop there. There will be support for the future. What will you be bringing to Worry in the future? I think that the purpose of this award within the observatory is to shed light, put the spotlight on initiatives, even though I think that where we is well communicated, we're putting the spotlight on the project. And also we will allow the development of this not only in Senegal, but we hope to extend this to all of our countries, because it is a problem that is common to all of our countries, even though I didn't hear you say Mali. But I imagine and I hope that we will find this in Mali one day. So I will let you give the award. We will take the photos. And we can give a big round of applause to Marina Green and all of her partners for this application and this award given to Where We.
Merci beaucoup, Marina.
Thank you very much, Marina. Please stay with us.
Je veux quand même remercier.
And I would really like to thank the foundation, Pierre Fabre Foundation, and your very serious approach to studying the different applications, because I've never seen a consultant come to our countries to spend 1 week with us to meet all of our partners and see what we were doing. So it was quite exceptional. So thank you for this. And thank you for having brought me here today, because I've already met a lot of potential partners. So where we soon will be soon in Mali and Chad, etc. Oh, what more could we hope for? Thank you very much. So yes, the awards are not given lightly. First, the applications are pulled apart by a committee of experts and specialists in e-health, and we also go into the field to investigate things. It's not always easy, but the people from the foundation go into the field and they look at everything that's happening in the field to see if what is written in the application actually corresponds to what is happening in real life. The final award of 2023 promotion, we are going off to Uganda. Uganda is the 3rd country of Africa to host refugees, more than 1.5 million refugees. And the Schmidt project is that of a smartphone and tablet application for refugee camps to encourage access to healthcare and detect possible epidemics. Let's have a look at this project.
They will register all the members of a household, and they will conduct assessments for children who are under 5 to check on pneumonia, malaria, and diarrhea. They will also assess pregnant women who may be at an onset of a pregnancy or much later. When they find something that is unusual on these assessments, they are trained to refer to a health facility where further care can be provided. The data is received and visualized in dashboards that help to inform the health system managers the status of the community. Health system managers can also use this information to determine where services should be sent. They can use it to tell where outbreaks might happen, and most importantly, they use this information to help determine supplies and materials that need to be distributed to the community.
Voilà, pour ce projet RCHMIS,
this is the RCHMIS project.
le prononcer, donc de travailleurs formés pour
So of people who are trained to help people in the refugee camps in Uganda. And to receive this award remotely from Kampala, the capital of Uganda, we welcome Brian Sugala, who is founder of
Agnès Kabalianga.
and Agnès Kamalomba. Brian, delighted to have you here with us remotely for this award ceremony. We can give them a big round of applause.
Je suppose, Brian,
I suppose, Brian, that you're very moved by the idea of receiving this award from the Pierre Fabre Foundation. Even though you couldn't travel to be here with us today, I'm sure that you're very happy today. What is your feeling?
Yes, absolutely. We're very delighted to be one of your awardees. And it's such a testament to collaborate with the foundation and also with all your partners for you to bring a spotlight and to shine a light on the work the refugees are doing in the country as they look after their fellow refugees in their community. So we're very delighted. Agnes and I and the team are very happy to join you today.
On a vu Brian en vidéo.
We saw Brian in the video and show the functions of your solution. What developments have you brought and what developments do you wish to bring to this solution now?
It's important to realize that community health work in the most hard to reach places is a very community volunteer service. The people who go to doorsteps and look after children, look after pregnant women, they do this for free. And so what we want to do is to really just bring the power of technology to help them do this job even better. It's important for us to think about what technology can do to change the life of a person providing care. What decisions can we help them to make better? And so we have built decision support in the Android platform. Most importantly, what data do they need to help them to provide meaningful care? How can they locate the household that needs care fast? So they're not just wasting time and going all over the village. These are all important aspects of using the power of technology to aid someone who is already providing care at the household level to do it even better, to do it more effectively, more efficiently, and then collect all of that data and present it to the managers of the health system. And that's what we're supporting in the settlements.
On entend effectivement les enjeux de rémunération.
Yes, we can hear the questions of the pay of these social workers and who train themselves and discover new technologies and how you work with tablets. You've told us also about the technological challenges of improvement and the data you need to collect. Is there also a geographical stake? Because this application is not developed everywhere in the country, it is only in certain refugee camps.
Yes, Uganda is a large 13 settlements, and what currently
et grâce à la fondation, on pourra
you need a solution that allows offline capability as well as online when we need to transfer the data. It's important for us to consider that these refugees have transferred from another country. This is not their home. But while they're here, they are offering a service to their community. And we come alongside partners like UNHCR, like IRC, like MTI, and we're supporting the work that's happening. We want to make sure that being a refugee or being displaced does not mean that you can't receive quality care. And the person providing that care to you may be a Ugandan from the host district, or they actually might be a refugee like you. We just want to make sure that no matter who it is, they're supported to provide care and to do so the right way.
Brian, il y a malheureusement, j'ai envie de dire, beaucoup d'autres pays qui accueillent
Brian,
des réfugiés.
unfortunately, there are many other countries who are hosting refugees who are political refugees or fleeing from war. Can your solution be easily adapted for these other countries?
Absolutely. There are certain things about a refugee settlement that are different from the host community. And so, although the application that we have built provides support to follow the guidelines for ICCM, for family planning, for pregnancy care, there are some unique things around a refugee settlement, such as protection and privacy. And so the data is not just sitting in the mainstream database. It's actually handled by officers working in protection within the refugee settlements. And that's a key thing, to recognize that by adapting to the uniqueness of a settlement, we're supporting regular care without paying the price for ignoring why are people in the refugee settlement in the first place. We want to protect that as much as possible, but at the same time, we want to balance that with quality care. And so the platform is totally adaptable across the region.
Brian, félicitations pour ce projet.
Brian, congratulations for this project, which concerns refugees, but also the training of people who take care of these refugees. So to give this award remotely, we will have Béatrice Guérin, who is director of the Pierre Fabre Foundation.
On va remettre Béatrice ce prix par écran interposé.
We will be giving this award via the screen to Brian and the teams in Uganda. Beatrice, what caught the attention of the foundation in this project? I would just like to say hello to Brian and Anne. Yes, to begin with, and to say wish you were here.
Pour leur parler, voilà.
Voilà. En tout cas, non, on a été effectivement.
In any case, yes, we were very enthusiastic about this project. And Ibal is with us in the room, and he went into the field. So if there are any precise questions, then he can answer. No, first of all, the foundation pays particular attention to vulnerable populations. And of course, here, this is a tremendously vulnerable populations who are in these big refugee settlements. You can imagine hundreds of thousands of people in these settlements, and people who stay there sometimes for their whole life. So historically, the foundation has always worked on refugee settlements in Lebanon and for a number of years in the Syrian camps. So we're very aware of this problem and happy to see the solution. So it's also people helping themselves. These community health workers come from the very community itself, and they know what the needs are. And it also means for them to grow, to help their own community and help to grow themselves. And it's a tool that works with an entire ecosystem, because there's the High Commissioner for Refugees who's working there with them also. And I'm delighted to learn that there is a third settlement that you will be working in. If I'm not mistaken, there are 13 in the country. And that means there's a lot of potential to develop this solution. And therefore, we're particularly delighted and proud to give you this award and to try to support this initiative and make it more broadly known. Yes, because how will you be supporting them now? Well, everything is done in a very frugal manner. The team that is working on site is working in very frugal conditions. So our help will horizontally help to support their working conditions, access to servers and premises. Very structural support we will be providing to begin with. And of course, the foundation can give a budget of 100,000 euros that is distributed between different winners. But for 1 year, we will be providing support and putting the spotlight and helping them to create a network in order to contribute to these initiatives and helping them to grow. So we can show you this award. Brian, would you like to say something to what Beatrice has said?
Yes, we'd like to thank you so much for the vote of confidence, for coming alongside us and recognizing that this support is tremendous in the work that we're doing. We know that there are many refugees that continue to come into Uganda, and the partners on the ground are overwhelmed. And so digitization, even though we all have the evidence that it can help to improve this work, it gets kicked down the list of priorities, and many other things get funded first. But I'm so glad to see that with this work, with the support that you're giving us, we're able to bring the digitization priorities back on the table. We're able to use this to work directly with UNHCR and the Office of the Prime Minister and the local authorities in the settlements to make sure that the resources are utilized well. The refugees that we're working with have just completed a usability study, and they've all expressed very positive results on the power of the digital tool that they now hold. We're so excited that we're going to be able to achieve one additional settlement or two before the end of the year ends. And I'm so glad for your support. Thank you so much.
Merci beaucoup, Brian. Félicitations, Agnès. Bon, on va garder
Thank you very much. Congratulations. We will keep the award on the table.
Brian,
way,
merci
everyone will be able to see it.
rester quelques minutes avec nous.
Thank you, Beatrice. Please stay with us for a few minutes.
Lauréats,
And we will see if we have any questions for our award winners.
Qui se lèvent dans la salle de les poser. On va vous apporter tout de suite un micro, monsieur. Et puis, sachez également pour tous les internautes qui nous regardent.
For all of the people who are joining us remotely, it's now or never. If you have any comments, questions, or things to some encouraging comments to make.
Oui, Eric Combe.
I'm Eric Combe, professor at the Sorbonne University for Tropical Diseases and Infectious Diseases, and I'm a dermatologist also. I wanted to ask you a question about WEARWE. Don't you think that this could be a good opportunity to educate as to the prevention of sexually transmitted diseases? Because I think that women are the main victims of MSDs, or sexually transmitted diseases, and the people. So they're no doubt more important to educate than men in this regarding this question. Thank you for this question. Well, rules are taboo in Senegal, and sexuality too. We made the choice of targeting young girls to begin with who do not have access to this type of information. And in order to gain access to these young girls in schools and in families, we cannot talk about sexual activity. When we talk about sexual activity or contraception, the door slams shut. So what we did is that we find a way to go around this. So in appearance, all of the WEARWE tools
n'ont rien qui choque.
Nothing shocking in it. We're talking about menstrual cycles, the well-being of young girls and health, etc. However, what we have done is that we have a partnership with call centers and midwife platforms who can provide this information. But that is in a one-to-one relationship where anonymously young girls can talk with
Donc, nous, on a le chatbot dans l'application.
And to find out information they need to find out. So we have the chatbot that can answer quite a lot of questions, but when it goes beyond our scope, we refer them to the midwife call center. And this is how we deal with this theme. Maybe we can take things a little bit further through the series, but in order to remain present in homes and schools, we have to be very, very careful. Any other questions?
Thank you very much, Marine. Congratulations. And when I wish I had this app when I was a young girl. As you try to expand to other countries, I'm going to play devil's advocate here. You might meet ministers of health who challenge you and say, with this app, you have the fertility data for my country. And you know how us as Africans, we are always worried about our fertility data. We think every vaccine is trying to curb our fertility. So how would you reassure such a person? Because you really do have a lot of fertility data that you're collecting across the whole country.
I have to admit that I never thought of that. At the moment, I know that we are collecting a lot of data that nobody has, because especially on this range of the population, the young girls, usually before 18, nobody has any data. So at the moment, we're collecting a lot of data, and I don't know yet what we can do, what we cannot do, and that's why I'm really interested in all the discussion we had today, because it's really crucial. So thank you for this one. I will put it on my list.
C'est une nouvelle piste d'évolution pour WIRWI à terme.
So that's a new possible evolution for where we. Any other comments or questions?
Je regarde une fois, trois fois. Je donne juste une remarque d'internaute.
So just a comment from, it's good to use AI to respond to certain needs of the South, but we mustn't forget to train a lot of healthcare professionals after this. And somebody else who's congratulating us for the debate.
Dernière question, monsieur.
A final question. And then we will move on to the conclusions. Thank you. A question for WIRWI. You're talking about new partnerships and the fact of going into other countries. What would be the main obstacles, according to you, that you will encounter? Main obstacles to deploy your solutions in another country, be it in Chad or any other country?
Alors l'application mobile, en fait, elle est
the
déjà
mobile app is already available across the world. So the first technical obstacle is that today we identify ourselves with a telephone number and we receive a text message for confirmation. So this telephone number service is not available in all countries. Therefore, you need to use an email address, and not all young girls in the countries of interest necessarily have an email address. So we're now trying to look at enrollment through social media so that we can work in other countries. So that's the technical aspects. It's not very complicated. But then there's the cultural adaptation, because we are very rooted in what we've done within Senegal. And that is the question. How will it work? Will the young girls, be happy? Do we need to change the names of the characters on the, for example? And that is what we're going to be working on in coming months. So we can see that it's ultra-local adaptation. What works in Senegal might not be the same characters in Mali, Burkina Faso. I don't know. There is a Senegalese series which is called The Mistress of a Married Man, which is a very big success in certain countries, and even before it was subtitled, it's been very successful in other countries, even before it was subtitled in French. Now we're in the third season of Where We Are, and we're starting to introduce young people from the Côte d'Ivoire to see if this can open us a door in that direction. So we're impatient to discover the next season.
Pour ces deux prix, et c'est donc la fin de cette conférence. Et pour
this brings us to the end of the conference, and for the closing, I will leave the floor to the World Health Organization. Alain Labrique is the director of the e-health department and innovation.
En anglais, on appelle ça le post-prandial slump. Ça, c'est quand tout le sang est parti du cerveau et c'est entré dans l'estomac. Et on essaie de recréer un petit peu la température du Sahel. On se sent bien chaleureux.
And get back to Sahel temperature. And we're just going to try and get everybody's interest back. I was born in Asia, so I need a lot of water. I'm going to have a sip of water before
I'm going to switch to English, and hopefully I will try to enunciate so the translators can keep up with me. But thank you so much. It's really a pleasure to be with you today, and my deep thanks to the Pierre Fabre Foundation, to AHIN, and to all of the organizers, and to all of the distinguished colleagues who are here today to be part of this dialogue and the celebration of achievement. I think it's really been a fantastic day. So I'm going to say, because the winners today deserve a round of applause, why don't we all just stand up for a second and give them a standing ovation. Well done. Really, really well done. Well done. That's another sort of secret intervention by WHO, because sitting is the new smoking, and so that was my secret way of getting you to stand up and get blood flowing into your bodies. So, bravo. Do I have a clicker? I think it's technology sorted out. So the foundation has long been a champion of innovation and the judicious and appropriate use of technology to address neglected global health challenges. And I think recognizing the innovators today have found ways to solve persistent problems. But I'd always like to start by talking about why I am here, right? What turned an infectious disease epidemiologist into a health informatician, into a passionate evangelist for digital health and innovation? And it's this powerful map. We all lived through this connectivity revolution that changed the face of the globe. You see the countries of the world here inflating based on the proportionate per capita ownership of mobile phones that happened between 2000 and 2016. And if you notice that, you'll see that there's a near overlap of the cell phone revolution. No, maybe? There it is. Of the cell phone revolution and the continued challenges that I mentioned a few minutes ago of maternal and neonatal mortality. We talked about the Boeing 747 crashing every 2 days. And for me, it's not just a statistic, it's personal. As my mother and I, yes, they had color photos back then, were nearly one of these statistics. When she died, nearly died of sepsis, giving birth to me in post-war Bangladesh, and I nearly dying from obstructed labor. You can imagine the size of this big head. But we didn't have digital health to rescue us at that time. My father went from clinic to clinic on his bicycle because there were no phone calls that you could make to gather 7 days of antibiotics in order to treat my mom and to make sure that I was alive. So we've studied now in my career as a digital health researcher the capacity of digital tools, sometimes as simple as a mobile phone call to save lives and change that trajectory to death to survival. And I think during the pandemic, all of you were with us during that, and we witnessed no less than what I would call a sea change, a dramatic shift in how policymakers around the world see digital as a catalyst for the Sustainable Development Goals. And it's clear, and the data is there. We've seen now studies of how countries responded to the COVID-19 pandemic, that there's no pathway to health for all without digital health for all. And today we've talked a lot about the cutting edge, we've talked about the future of digital and AI, but digital requires us to also talk about health system strengthening. We have to talk about the way the World Bank report recently framed it. They said, stop talking about digital health. We should start talking about digital in health. And that means it's routine. It's digital as a way to pay health workers. The first example we had this morning was about M-Pesa, the one technology that has revolutionized the way financial inclusion operates in most of Africa. To optimize scheduling. I know for a fact I couldn't survive without my Outlook calendar telling me what to do from 1 minute to the next. And that works in countries to help health workers optimize and prioritize who they visit on a daily basis. To monitor supply chains so that we don't have to wait till essential drugs and commodities run out in a clinic before you realize, we need more supplies, and then you wait for a week before those essential antimalarials are available in that frontline clinic. And last but not least, and I really want to highlight the close and supportive relationship that we received from our colleagues at Google during the pandemic to make sure that people everywhere had access to truthful, reliable information about how to manage the pandemic at an individual level. So digital allows us to define the population denominator, enabling accountability systems that allow us to define whether health services are reaching all of the people who deserve to receive those services. We talk about things like the last mile. We talk about things like universal health coverage. But as an epidemiologist, if you don't know the denominator, how do you know the percent of population that you're serving? to this day, and for those of you who are not, dyed in the health field, you will be shocked to imagine that we do not count every maternal death. Maternal mortality today is still estimated. And if that doesn't keep you up tonight to think that a pregnant woman dying somewhere in Africa or in South Asia is an approximated statistic as opposed to a count, that is something that's really we need to be solving for. We need to be solving for our overburdened health workers who have already so much to do, and we keep loading them with more tasks, but we have to be thinking about how digital can optimize and enable them to make sure they're spending time caring for patients, not filling in accountability forms for one donor or the other. I also want to remind us that when we talk about digital health, we should be focusing not on the technology or the gadget. We're talking about primary health care. We're talking about UHC and timely, better data for decision making. We have to work at the government level so that all of these data, we talked just now about a massive treasure trove of data that's being generated by one of these systems. Is that data being used to make decisions about healthcare and optimizing resources in communities? Most importantly, we're talking about equity, including those who have typically been left out or left behind. And we know digital health, as we've heard today in many examples, digital health is a proven pathway to reduce those equity gaps. But we have to make sure we're using the limited resources that countries have to allocate to public health, that those resources are used widely, and that we're not chasing shiny objects or magic solutions to solve these problems. And that's really to credit Pierre Fabre, the rigorous process that you've used to evaluate some of these, all of these winners is really a testament to the value you're placing on evidence and not just the nicely produced video that anyone can produce today with AI. So our member states now are talking about something different. They're talking about digital transformation. Digital transformation. So transformation, when you hear the word transformation, transformation is not about incremental change. Transformation is about reimagining a health system. It's reimagining the health strategies that were developed sometimes 10 years ago, sometimes 50 years ago, sometimes 100 years ago, in a paper-based environment. So we have to ask ourselves, are we doing something today because it's the best way to do that thing? Or are we doing it today because that's the way we've always done it? That's the way it was created when we only had these stacks of paper to register all of the women in our community to whom we have to provide antenatal care. So the question I would ask all of you who have come from so far across Sub-Saharan Africa or South Asia, or for those of you coming from Central Asia, ask yourselves, are you doing things the most efficient way in 2023, or is it because that's how the system was conceived over a decade ago? WHO is the secretariat for something called the Global Strategy on Digital Health. Let me ask you, how many in the room have seen this document? So that's a bad news for me in terms of doing the appropriate public relations, because this document is a document that was created by all of the member states. 194 countries have ratified this document that's a 5-year plan from 2020 to 2025, for which WHO serves as a secretariat, outlining tasks and goals for countries, for partners, so many of you in the room are partners, and for WHO to undertake to help countries achieve digital transformation. I would love for all of you to go back and when you're looking for something to read, as you're falling asleep, pick this up and look through it and ask yourself, how does the work that I am doing in AI or digital transformation, how does my work fit into the agenda of the global strategy? Because the strategy is meant to unlock that pathway to transformation, but with one small detail. It puts government in the driver's seat. It allows government to set the rules of the sandbox so that everyone can thrive. Private sector, entrepreneurs, public sector, NGOs can work together in a common strategy to achieve that digital transformation. Last week, I was in New York at the UN General Assembly, and there were two topics that were at the top of everyone's list. One was digital transformation and digital public infrastructure, and the other was artificial intelligence. So let me just start with digital public infrastructure, or DPI for short. WHO believes very strongly that you cannot achieve digital transformation without investing in robust foundations in infrastructure, architecture, policy, legislation, and human capacity. It's the equivalent of building skyscrapers or health systems without the foundations or architectural plans. We wouldn't have this beautiful auditorium if there wasn't a carefully architected plan and the qualified people to actually build it and put it together. The same is true for national digital health systems. This digital implementation investment guide proposes this generic blueprint, as you see here, for this transformation journey. And it's important to see where it starts. It starts here with national priorities and the digital maturity of the country. That's what helps create the strategy that leads to the roadmap, that leads to something that my team keeps telling me at WHO. They're like, Alan, don't go to Pierre Fabre and talk about enterprise architecture. This is not what they want to hear. But enterprise architecture is sexy. It is the thing that we all need to be going out there and telling our ministries, do you have a strategy for enterprise architecture? Because without architecture, we're just building in the sand. And within a few years, those things dissolve and slip away into the ocean. So we have to make sure we're moving forward with building architecture. We've seen, and this is data, if you don't believe me when I tell you architecture is sexy, this is why. The Gates Foundation commissioned a research to look at all of the investments that have been made over the last 15 years on the continent of Africa. And what you see here is the number of tools, 880 apps and platforms mapped by the Gates Foundation, only less than half of which have scaled nationally. Less than half of which have scaled nationally. So it's important to understand that if they're not supported by an enabling environment, they don't fit into the national strategy, and these enabling environments don't support them with viable, sustainable business models, these systems don't flourish as part of a complex health ecosystem of other solutions. And it's really that interoperability that we have to be thinking about. So WHO has been involved in supporting member states in digital health for over 2 decades, with many member state resolutions and a global strategy that I just described that encapsulates our mandate to help bring leadership to the space and help to serve and support the countries who give us that mandate. Over the last 5 years, there's been the formation of a new Department of Digital Health, which I have the privilege of being a part of. And there have been some key technical products, including evidence-based guidelines, which I'll share with you in just a moment, as well as a classification of terminologies around digital health. And we have colleagues in the room who are using that classification and even making it better, as well as the Global Strategy 2020 to 2025. We've published this implementation and investment guide. So these are some of the resources for those of you who represent governments or work with governments. These are some tools that you can take back to say, are we following these guidelines that have been developed with some of the best minds in the world to help guide countries to move forward? The evidence-based recommendations for digital health system strengthening, it's great to see that many of these things are strategies that were reflected in the winners of the awards today. That from birth registration to death registration to telemedicine to supporting health workers, these tools in digital health are being used across the digital health landscape. We're excited by a number of new activities that were launched in this calendar year. I'm just going to take a moment to share them with you because I think they have implications for the work that you're doing. One is the new Global Digital Health Certification Network. And this is supporting a number of member states. Currently, at one point, we had about 84 countries as part of this network. We hope to make it as far as 194 countries. But this allows people, yourselves in the room, to cross from one country to another, carrying certified health information about yourself that other countries will accept. Many of you who lived in Europe experienced this during the pandemic, where you in France could take a COVID certificate and go to 80 other countries where they would accept your COVID certificate because you were part of a broad trust network. So digital yellow cards, portable health records, these are things which this kind of trust architecture enables. WHO now serves as the trust anchor or the phone book for this public key infrastructure, allowing people to move across borders with their official health information. Someone earlier asked me about telemedicine, and this is the architecture that enables cross-border telemedicine. Imagine a future where you can get care from a doctor who speaks your language instead of the language of the country you're visiting. We just launched, and something we're very excited about, a global initiative on digital health. And this is something that we're hoping all of you today who are in the room will become a part of. Whether you're a foundation, whether you are an implementing agency, a Ministry of Health, this is an initiative that looks to align and amplify the work that you're doing so that it doesn't stay trapped within your country or your region, but the entire world can benefit from those insights. The 4 pillars of this global initiative will help countries accelerate how they express their priorities, make sure they have the technical, financial, and human resources that they need to make sure they can undertake digital transformation, make sure that they have the tools that they need in terms of whether it's AI or whether it's a national workforce registry, that those tools are available, and that we have platforms for meeting and exchanging ideas like we have done today in this kind of environment. And finally, a global initiative on AI for health. So many of you are asking, how are we going to solve this problem of capacity in AI for health? And I'll say this is the initiative with ITU, with the World Intellectual Property Organization and WHO together is launched this 3 months ago. So we've drawn on the expertise of over 150 experts in the field of AI, from academia, from industry. Our colleagues over here at IDARE have all contributed to develop technical guidance on the ethics and governance of AI for health, on how to generate evidence for AI as a medical device. And I apologize if the QR codes are too small, but you'll have copies of this talk later on. And 5 days ago, we just launched this new report, which was the basis of our discussion earlier of the regulatory considerations for AI for health. I just added on the slide the QR code for the course that someone was asking earlier. So this is the course that's being offered on AI for health on the Open WHO website, where we've had over 10,000 learners complete the curriculum. The Global Initiative on AI for Health builds on the work of the AI for Health Focus Group that has been in operation since 2018. So there's a lot of historical and collective wisdom that's embodied in that group. And I think we have colleagues from MIT. I put him to sleep, unfortunately, so I'm going to speak softly. The focus group, it's fine, it's fine. I'm also almost asleep, so don't worry. It's the jet lag. The focus group tackles a range of topics. He's going to get me later, don't worry. But it's focused on a range of topics ranging from the guidance that we shared earlier, but continues to work on things like data specifications, on training, as well as scale up and adoption. So if anyone is interested to be part of this think tank of advancing the boundaries of how we think about AI, please come and talk to me, and I'll point you to how to join this focus group. So just to say, for example, this document, this is the ethics document. Someone was asking earlier, does each country have to start from zero? And as Fazila pointed out, the answer is no. You don't have to start from zero because this is the collective learning of our 194 member states, which all of your countries are a part of. And for example, these are the key ethical principles that has come out as a consensus across those 194 countries as a starting point for around which you can build a national set of standards and regulatory boundaries. The Global Initiative on AI for Health will develop more technical standards and policy guidance and facilitate knowledge and data sharing, and will support evidence-based decisions on the introduction of AI solutions for health at a national level. We're prioritizing not the high-income countries, so my apologies to France, but we're going to be focusing on supporting countries who are trying to accelerate into the digital transformation. So we're looking for partners who are interested from the technical side, from a funding side, to be part of this global initiative. We're receiving at WHO many, many requests, and we're going to be expanding our capacity to help guide countries in AI. Whether we're talking about TB or cervical cancer or diabetes or AI for pandemic surveillance, these are all the domains that we're getting constantly bombarded for guidance on from countries. So guidance is being developed and will be provided as fast as we can produce it. We have several AI tools that have gone through pre-qualification processes and are currently under review. And I'll talk about just a few of those in just a moment. But I will re-emphasize again that we need infrastructure. We need architecture in order to do these things well. We can play around and have a few pilot projects that show results for a short time, but long-standing transformation has to have us investing in those foundations. The two areas of great potential that I'll just focus on, in addition to the ones we heard today, include cervical cancer, which is a highly curable, common form of cancer, primarily affecting low and middle income countries. And research into AI-based cervical cancer screening is showing significant promise and is being reviewed by technical teams for both secondary and tertiary prevention. A roadmap for generating evidence for AI-based medical devices based on cervical cancer screening was published, and this is also available to study. As you're asking yourselves, how do I generate evidence for, let's say, diabetic retinopathy? Look at this document and try to mirror those pathways to do the same thing in Rwanda. Second, TB, a major cause of preventable mortality worldwide, another big focus and success story from this year's UN General Assembly, is something that is a major concern for WHO because of the impact it has not just on people, but on children. And we're seeing promising data on AI-enabled diagnosis in, especially in children, improving clinical decision-making and potentially earlier treatment detection. So you're seeing here some images from lung imaging that helps to diagnose and recommend treatment for pediatric TB diagnostics. And also AI for diabetic screening. I think the data and the evidence base around diabetic retinopathy is growing very, very fast, where AI is enabling task shifting and rapid screening in countries, for example, here, a project from Egypt that has shown a substantial promise. So I'll end with just a few reflections that AI seems to have taken the world by storm. And I said earlier, it's taken the media fascination with artificial intelligence, primarily because of large language models and ChatGPT and multimodal models, right? If you don't know what a multimodal model, it's when an AI can learn how to use a piece of software and not just interact with one space, but can create music or can direct a robot to do some work. And now you start to get an AI that is more than just ChatGPT. And there's been a lot of sensationalism in headlines that the life as we know it is coming to an end. I tried to find a few to put here on the screen, and Elon Musk came out and said, run for your lives. AI is going to be the end of us. But AI has been part of our lives now for many years in machine learning algorithms embedded in our cars. If you have a car that was built after 2017, 2018, there's an AI in there. And I don't know that it's trying to kill you. Behind the scenes in social media platforms, in Twitter and Facebook, there's an AI working to make sure the friend that you really don't want to hear from, that's the one who they're showing you pictures of. Robotics is a key discipline in AI, but we're not running from the robots. I think one key difference is the switch, and this is a very, very French thing, because in French history, the development of automata, in the 17th century, the French clockmakers were building robots that could write Voltaire poems and birds that could sing songs. You go to the museum in Genève of the watchmakers, and you'll see these beautiful birds that are clockwork. They're automata. You wind the key, and they sing a beautiful song. And that's what we like it. We like it when we push a button and we know what comes out the other end. But now we're coming into a territory where we push a button and you're not sure what's coming out the other end. And it looks and feels more like us. It looks and feels more like the humans that we work with, the medical students who make mistakes when we put them to treat patients. But we don't turn off the medical student. We train them. We improve them. We make sure they do better each time. And then we see their error rates go down. So one important thing to remember as we go into this conversation, and I apologize if I've said this 3 times today, but it's critical. AI is a very broad term. It can refer to vastly different things depending on the task that's being performed, depending on the level of autonomy, depending on the risk of the situation. And so as you speak about AI, as you speak about the opportunity, the risk, the regulatory needs, right? These are different based on whether it's a hippo, a giraffe, or an elephant, right? And I think it's important that we keep that in mind and be clear in our discussions. We had the same problem in digital health. We had the same problem in M-Health when we started. We're bringing engineers together with doctors, together with informaticians, and we all speak different languages. And so when I said, I'm going to do a trial as an epidemiologist, the engineer was saying, oh yes, I've done 3 trials. I said, really? You've done 3 trials since yesterday? He said, yeah. But we were using the word to mean different things, so it's important to have that synergy. But if there's one area I'm gravely concerned about, one area, it's the intersection of AI and disinformation. Intentionally created and propagated false information. It was a big concern for public health, for the anti-vaccine movement, for spreading lies about polio, for spreading lies about HIV. And we've known for many years that this is a political tool to erode trust in science and erode trust in public institutions. And LLM-based tools today give everyone the power to generate high-quality, believable content that can mimic world leaders, that can mimic health authorities, and convey false information in very believable ways. And we must take it very seriously, addressing it both by training people. We all need to be aware of how do we distinguish AI from real content, but we also need to think about technologies. Sorry, I'm getting a call. Let me see what this guy is asking.
Congratulations to the Foundation Pierre Fabre for this wonderful event. Bravo to the winners.
Sorry, that was President Obama. He just wanted to say thank you. You know, when he calls, I'm sorry, I have to take it. I can't just, you know. But you can see what I mean, right? So I'm really excited by these conversations. I thank you at the end of a very long day for being so patient. I look forward to continued engagement with the Foundation and WHO, with all of you. Let's use these tools to change the world for good. Thank you.
Merci beaucoup Alain Brick pour cette somme de connaissances que vous nous transmettez.
Some of knowledge that you are sharing with us, and your enthusiasm and your humor, which could almost be British.
C'est donc la fin de cette
So this brings us to the end of the conference.
Va me rejoindre tout de
will be
suite.
joining me immediately. Beatrice.
Un dernier mot de la fin.
Yes, for the conclusive words. Well, not the after this brilliant closing keynote and the vision of the WHO and all of this work and this global vision what more could I say? Well, actually, we have a lot more to read in order to fit into this global vision in terms of our experiences in the field. Thank you to everybody, to all of our panelists. Congratulations to those who have so truly deserved the awards given today. I would also like to thank ourselves, the organisation.
Qu'on peut applaudir.
And we can give them a round of applause, yes.
C'est un gros boulot.
It's such a lot of work. It's taken many months to bring all of this together. So thank you, Maxine and Caroline. Thank you to the team who looked after the logistics, and Marine, Deborah, Vicky. I hope I'm not forgetting everybody. Of course, thank you to our committee of experts who are all here with us today, Jakuma and
bien sûr, notre ami Jai.
Our friend Jai. I would just like to remind you that this conference has been filmed and it's visible by streaming. So, and it will very quickly be accessible online. And it will be subtitled in English and in French so that you can pass it around. So I would like to say to everybody here that this is a key point for the Observatory, but in the Observatory is an everyday endeavour. So please don't hesitate to contact us. We try to make the networks as fruitful as possible among ourselves, among all of those who are listening to us. So do get in touch with us.
Les défis sont immenses.
The challenges are tremendous and also very exciting. And we'd like to feed this large community so that technology can be as inclusive as possible and then it can help to improve the health for all. Thank you very much. Thank you very much, Beatrice. Thank you to the foundation. Thank you to those who were with us remotely and see you next year.
Jean, merci. Pardon. Non, juste un petit mot pour vous, s'il vous plaît, vous demander de ne pas oublier de laisser vos casques.
So please don't leave with your headsets, because every year we have 3 or 4 people who forget to leave their headsets here. So please leave translation.